So we just see whether you can have it in the first session, because I think I think I may have to leave to the airport.
Yeah, I'll just talk to Marwa sir. 1 minute. No.
You always first one. Sir, first.
Okay. Yes, sir. So you will be your session is has been kept first.
Okay, so I can introduce Dr. Gangadhar when you start, and then
Yes,
once
sir.
you say,
Yes. Yes.
okay, fine. Yeah, great.
Okay. So
Yes. You're the first.
Om Amriteshwarye Namaha. Humble pranams at the lotus feet of our beloved Amma. It is our great pleasure to warmly invite you to the fourth annual National Undergraduate Medical Summit, SPUST 2021. It's our great pleasure to be here today. And isn't it fascinating how a tiny cell manages to malfunction and cause a plethora of problems in our human body? Malignancies produce the most destructive manifestations of what we fear the most in a disease. Not only does it challenge the physical, mental, and social well being of oneself, but it has implications on the life of those around you. Today, some of the most eminent speakers have honored us with their presence. As a preamble to the session, we have Dr. Chirag Sunil Lalwani, House Surgeon of MBBS 2016 batch. He is a proud author of 10 papers published in prestigious journals and is an avid quizzer who has taken part in several national and state level quizzes. He was one of the key members for organizing SPUST 2019. Over to you now.
Good evening, everyone. A very warm welcome to all the esteemed faculty and respected colleagues. I'm Dr. Chirag Lalwani, presenting with a brief talk on what a student's perspective into this specialty would be, medical oncology. My presentation is going to be pretty brief. It's going to cover some introductory sentences, as well as some questions that we as medical professionals face from time to time, what the future of oncology is going to be made about, and finally, I would like to conclude with a quote from one of my favorite books that I've read. Now, what is oncology? It's derived from the Greek root, onco meaning mass, swelling, or tumor, logy meaning study. The graph seen next on your screen conveys a very important data set. In the year 2004, the incidence of cancer in India was just over 8 lakh. Incidence means new cases. And then in the year 2010, it crossed 10 lakh. In the year 2015, it was beyond that. Do you want to guess as to how many patients were diagnosed with cancer in the year 2020, in a period where screening was very low due to COVID? The number is 13,92,179 new patients only in India. And this is data represented by the National Cancer Registry of India. As students and as medical professionals, we always face certain questions from time to time, thinking about how do we progress, what is the right way to talk to a patient, and so on. So, talking to different students in my batch and the junior batches, we've come up with a few questions that we would love to learn from this session. One of them being, what is the pattern of cancer across the world and in India? How do gender differences compare with each other? How has it changed in the past 2 decades? Which cancer has increased? Which cancer has decreased in its prevalence? What are some of the newest atypical presentations of cancer that we notice nowadays? In my house urgency year, I've noticed cases where a patient must have presented with something as benign as altered sensorium and found to have breast malignancy, and or the ultimate diagnosis of that being paraneoplastic limbic encephalitis. So we are seeing new types of presentations coming up every day. What must we as medical professionals monitor actively to keep an active lookout for? How does one, as a medical professional, deal with the affective and cognitive domain of this specialty? How does one manage the reaction from a patient after breaking really bad news? And one of the most important aspects in any specialty that we talk about, communication, because these are just few words with life-changing implication for every patient. How can one uplift the physical and mental aspect of the patient with poor prognosis? What was the impact of COVID-19 since 2 years? What has been the impact of vaccination on cancer patients? What are the newest, some of the most cutting-edge advances in management? Does it change the field forever? And what is our hope for the future? What is our motivation? And what lies ahead? I would love to conclude with this following quote, written in the book called Being Mortal by Atul Gawande. Our ultimate goal, after all, is not a good death, but a good life to the very end. Thank you.
Thank you, Dr. Chirag. Well, that definitely gave us something to ponder upon. Now, it is my great pleasure to welcome the chairpersons for this session. I would like to welcome Dr. Radhamani K. She completed her undergraduation from TD Medical College, Alleppey, DGO and MD from Government Medical College, Calicut. She has been a professor of obstetrics and gynecology at TD Medical College since 1990 to 2008 at Pushpagiri Institute of Medical Sciences, Tiruvalla. She has been working at AIIMS, Kochi since 2009 and currently is a professor and head of the Department of Obstetrics and Gynecology. Now, I would like to welcome Dr. Subramania Iyer. He completed his undergraduation from Medical College, Kottayam, MS from the All India Institute of Medical Sciences, New Delhi, MCH in Plastic Surgery from the University of Calicut. Before joining Amrita in November 2003, he was the head of the Division of Head and Neck Surgery and Reconstructive Surgery at Amla Cancer Hospital, Trichy. Currently, he serves as a professor and head of the Department of Head and Neck Surgery at the Amrita Institute of Medical Sciences. Now, I would like to welcome Dr. Mala Mathur Sharma. She completed her undergraduation from Armed Forces Medical College, Pune, MS from Premier Cancer Institute of India, Tata Memorial Hospital, Mumbai. Dr. Mala joined Amrita Institute of Medical Sciences, Kochi in 2014 as a faculty after taking premature retirement from Armed Forces and has been on teaching faculty in the Department of General Surgery. She also has been actively involved in promoting and performing oncoplastic breast conservation surgeries in this institution since 2014. Currently, she is a professor in the General Surgery Department in the Breast Disease Division at Amrita Institute of Medical Sciences, Kochi. Now I request Dr. Subramania Iyer, sir, to introduce our guest speaker, Dr. V.P. Gangadharan, sir.
Thank you very much. It's great to be part of SPARS 2021. And you have sent me a note about Gangadharan, what should I talk about him, but I don't need to look at that because I know him from, probably know each other than anybody else. Dr. Gangadharan is a legend here in the field of medical oncology. We are proud to have him all over, I was his batchmate in MBBS in Kottayam, And in fact, we did our post-graduation together in All India Institute, where he did his radiation oncology. Then he came to Kerala and then did an unusual thing, because he thought that a radiation oncologist should have a sound knowledge about general medicine. So he must be one of the very few persons who were trained in general medicine, did an MD in internal medicine from Kottayam. And then he didn't stop. And then being a complete oncologist, he he did his DM in medical oncology. So I would say we are all lucky to have him as the speaker for this meeting, because one of the most complete oncologists you can ever have, and who has marked his way in marked his he has been a legendary figure in the field of oncology in the state and the country. He has been a prolific writer. He has written lots about cancer and his experiences with the patients. More than anything, I think he has a great sound academic knowledge is everything stupendous. But more than that, his humane approach to patients, that is what is most striking. Any patient who has gone through his hands will feel is that magical touch of that healing, as well as the way he approaches the patient. So to start with this first talk, I don't think there is anybody else. And then the topic is how to approach a newly diagnosed cancer patient. And I would request Gangadharan to start his talk.
Thank you, Dr. Subramanian, I think, for the nice introduction, and happy that we could see face to face now after a little bit, few breaks following the, of course, COVID. Otherwise, I think we were meeting much more frequently. I think the topic is really a topic which needs a lot of, inputs and thought processes, always I feel. The first thing I would like to emphasize and point out is that disclosing the bad news or disclosing the news, whether it's bad or good, I think let me call it a news. It's more of a art rather than a science. I don't think there's any scientific guidelines is going to follow for you to have a disclosure of this. So it makes a sense to say that it's not the same Dr. who started practicing 30 years back and who is doing it now. The change mainly is if I required, say 1 hour to have a discussion with a patient and then convince him or then bring him back to the positivity, now I may require hardly 5 to 10 minutes. There is a change which has happened over the years. And that is why I said it's only through practice. The reason being, each patient is different. Each individual is different. Their mental status is different, mental makeup is different. And the acceptance is also different. And you are going to tackle each one. That means you have to get yourself tuned to the different patients. And then only you will be able to do that. And the first lesson is better not to talk much more better is to listen. That is where I think we all doctors are going wrong. Seldom we allow a patient to speak for more than 30 seconds. We'll immediately intervene and start dictating or saying our words. And we feel that they are the people to hear and you are the person to talk. To the undergraduates, specify and say that as an oncologist, you should have a good ear than a good tongue. That means you should be ready to hear their words. That itself is something which gives them a solace. So to start with, the first lesson which you have to learn is that it's always better to call a patient by name than by numbers. Just imagine for a while, you are sitting in front of a bank or in front of a OPD, and somebody is coming and said, token number 9, please come inside. And suppose somebody comes and calls you, Adul, why don't you come inside? That is a humane touch. So to start with, I will always address every patient by name and never by any numbers or without name also, because that gives a personal identification for the patient. So that starts with. The next thing I think always I tell is, you had to be in tune with the patient you are going to speak. That means you should come to the same wavelength of the patient. Then only you'll be able to communicate. You'll have a good rapport. That should be your approach. I'll start with my own way of thinking rather than going for any of the modules or any of the scientific aspects. The first thing probably I'll have to disclose when a patient is coming to me is, I'll have to disclose the diagnosis. Always the diagnosis disclosure should be there. So I'll not jump straight away into that discussion at all. Never, never, never. I'll usually start with, ask them, where is your house? And what is it? Especially if there are kids, they will invariably ask them, what is your area of interest? And you talk some 5 minutes regarding that. Like some may be interested in sports. Somebody may be interested in movies. Somebody may be interested in reading books. So you just have a small chat with them and try to share. Like there's a finally it's going to happen in cricket now between Australia and of course New Zealand. So that must be the hot point for me for a discussion. If there's a patient is coming and meeting me today, who will win, or why did India lose? Like that, I think you have a small discussion, because that gives a rapport between the patient and yourself. That's the first thing to be established, whichever you feel like, and that is where you start your discussion. Then the next question immediately is, you tell him in a very, very so the question always asked in any forum is, are you going to disclose the whole diagnosis and prognosis to your patient? I think the Western literature and any textbook will teach you, yes, you should be very open to the patient and you have to disclose everything to the patient. But my answer is no. I will say, in our setup or in our social background, our culture, everything, I will not disclose the whole thing with the patient. You know why? I'll disclose, but in a much more better way. I'll tell you an example. Nobody will like to hear from your mouth or any mouth that you are going to die after 6 months, or your lifespan is going to be 1 year. No, I don't think that any of you, it's not be cancer or any other disease. Nobody will like to hear that news. So I don't think that I will open up saying that you live for 6 months or you live for, no, that's not the way. So you usually start with saying that, see, you have got a problem. I'm just starting it now. You got a problem. And it's a cancer which is affecting whichever organ it is. And your options are there. There are different options are there. Don't get upset at all with the diagnosis, because there are a lot of options in front of you. And we'll slowly start the options. Suppose it's my area of chemotherapy. The first question to be addressed is, what is side effect? I think I'll have to address that first then probably. And that is again, you can put in different ways. Say, suppose I'm going to tell the patient that you are going to lose all the hair and I'm going to give you chemotherapy. Then I think it's a very bland way of expressing that. I put in a much more, polished way, much more sweet way. I'll tell the same thing in a different way. You can decide. It will be a better choice. I'll tell the patient that there's a chance that your hair will get lost. You may lose your hair. But one thing is very clear: 100% your hair is going to come back. So it starts in a reverse way. I think that there's a chance that you may lose your hair, but 100% is going to come back. And immediately I'll say, if it's not coming back, you go and sue against me, because I promised that the hair will come back. Because that gives them a different tone, rather than saying that you will definitely lose your hair. No, that's a way of presentation. I think better way of presentation. And if there's a patient or some other patient who is sitting outside, who had chemotherapy and who had a hair loss, and they're coming back with a normal full hair, I'll call them inside. and show them and say that, see, I didn't lie to you. There's a living evidence sitting in front of you who had chemotherapy, and she went through all the chemotherapy, all the toxicities, and she's coming back and sitting in front of you now. Then I immediately tell her, once you have a discussion with me, go outside and talk to her so that you'll have a much more face-to-face, interaction with her and know from the mouth itself as to what is the outcome. So the time I'm going to spend like 30 minutes, 45 minutes to explain a side effect or explain what is going to happen, I think that patient will need hardly maybe 1 or 2 minutes to convince the patient that yes, I think should be possible. So that's one thing I think always I say, that I think put it in a much more presentable way. That means you are going to present the same thing in different way. That means side effects, everything will be going to explain to the patient. The next question, I think all the minds of all the patients are, will I be able to continue with the work? Like if it's a youngster, he'll always say that, will I be able to continue my studies, or will I be able to continue with my profession? I think it's a dictum that you should see that the patient enters the same track. This is a derail now, because once the disease comes, they are derailed from the track they are away. At the earliest, they should be allowed to enter back the track. That means if it's a student, I'll say that yes, you should study and you should not discontinue your studies. And we will make arrangements for you to write the exam. And we have done that. We even have done that. A CBSE exam, one boy wrote the exam, an acute leukemia patient wrote the exam in the hospital, in the room, the special invigilator to look after the case. That's possible. So that is because that gives a kindle for the patient that yes, I will be able to do that. I'll be able to continue or pursue my studies, pursue my profession. That's very important. So it's mandatory that as an oncologist, you should see that you are not disrupting their routines or profession for a long time, because they should come back to the previous state. So that is again something which you should be able to disclose and tell them. For a child, for a pediatric patient, the pediatric patient is many people think that pediatric patient is very difficult to handle. I will always say that they are the easiest to handle, very easy to handle. It's an amount of convincing that's enough for them. Or they should feel that you are very lovely, you like him, and like that you can start the talk. And within minutes, I think that child is in your hands with you, and he will obey whatever comment you are going to make. To say that for a child and tackle and then taking into your life is something which I think is again something which you always love and like to do. That's why I'm telling that you cannot have a bland plan of action saying that you do this, you do that, and then I think that's a better way of telling. No, it's not like that. You have to individualize and then plan the disclosure. Regarding the prognosis, I told you, you should be honest. Don't think that you can say that every patient coming to you say that, no, I'm going to cure you, or you are going to live 5 years, 10 years. No, you should be honest. But that honesty cuts off at a level. That means you will not, I told you initially, I'm not going to disclose the whole thing to the patient as a whole. But at the same time, I'm going to discuss the whole thing with an immediate relative, maybe son, maybe father, mother, like that, and tell him that this is a stage of disease like, and prognosis something like this. But I will never commit regarding the when are you going to die? No, I think that answer is something which I never give. I tell that by scientific means your chance of his chance of coming out of the disease is this much percentage. And I always feel that I think many of the people have already discussed saying that the predicting that is not the duty of an oncologist or not the duty of a physician. You are going on a scientific term. You're going on a scientific term. With that scientific term, we can say this is the probability. And this is, to a level which I can discuss, but there is something above. However you want to discuss, you can discuss. But that is the point where you can say that I can tell that this is the percentage of chance of him coming out. And but the rest, I think, is something which you have to leave to your God, or whichever way you want to say. So like that, there is one person to whom you disclose everything, and regarding the cost factor. Cost factor is something, again, I think you have to be open. You should be able to tell the patient as well as the bystander as to what is the likelihood of the cost that is going to be implied in this. And that, again, I'm telling you, honesty is mandatory. Never, try to, hide things and tell them, and saying that this is the thing. I think that's not the way. So honesty is, I think, something very, very important for an oncologist. When not only for an oncologist, for any treating doctor, when you're disclosing something to the patient. I think the different difficult part which I always used to feel is, I think, when he asks back questions like, Doctor, what do you think is my stage, and what is the my chance of current disease? I think we'll always say, especially for a cancer patient, I think there is two or three things which as an undergraduate you should know. A cure is not the only aim of a cancer patient treatment. Cure is one area is cure. You've got an equally important 2-3 more aspects. That is means prolonging the duration of life with good quality of life. That means you are not curing the cancer patient, but at the same time, you are allowing him to lead a normal life. Now you imagine for 1 minute, you are not curing any diabetic patient. You are not curing many of the hypertensive patient. They are all live with the disease and live normally. That means you are controlling the hypertension, controlling the diabetes, and living normally. Like that, you've got a good number of them, right? 30% of the disease where you can say that you are going to control the cancer and live for a normal life. So I think that should be in your mind also. So you should be able to tell them that even if I'm not able to cure you, I think I'll be able to definitely control the disease and give you a quality of life. So like that, I think with a good scientific backup, you should be able to tell. That means when you discuss a patient with a patient regarding the diagnosis and treatment, you should be able to scientifically, know everything about the disease, the chance of survival, the chance of cure if it's there, or prolongation of survival there, or the side effects, everything you should be able to, along with, very, very important in the Indian scenario is, you should be able to say the cost of treatment and modify the treatment based on your assumption of how much the patient can go. I'll tell you, the bystander is going to come and ask you, and you are going to talk to the bystander saying that, yes, there's an option for this patient to go for a transplant. And at the same time, see, I'll be able to give almost the same result by going for a maintenance treatment like that. And there's a slight difference, but cost-wise is markedly different. So the question immediately the bystander is going to ask is, sir, if I'm not able to treat my father with this treatment, don't you think that I'm not doing the right thing to my father? I will immediately explain to them, no, it's not like that. See, you are discussed with your chance of disease. I think this is only this much. So even if you are not going for a treatment, shelling out everything in your life and becoming and totally debit, I think no, you are not doing the right thing, because you have got almost equally same result is going to come out with some other form of treatment also. So like that, doctor should be a pivot to explain everything to the bystander and say that even if you are not going to treatment, don't think that you are not doing the right thing to your father or your son, like that. So that means you are going to convince them, saying that your track, what you're going to take is different. So it's a very pivotal role for a doctor to address all these problems. That's why I said, when I started and told you that it's not a science, it's an art. It's an art of you, how you express your words to them, and how do you do that. Now coming to one more part along with this. Why you speak so much about cancer patient alone? Because all the specialties show the same problem. But there is something unique for a cancer patient. You know why? You know why? The cancer patient always feels that he is unwanted in the society because he has been diagnosed as a cancer. So he's an unwanted person in the society, unwanted person by the parents or by the children, like that. This feeling happens for them. That means they feel that they are lonely or left lonely. This should never happen. If you are seeing a patient Or if somebody else in your family is a patient, then I think be clear that you should be able to stand with them and make him convinced that whatever may occur, I'm going to be with you. In any, I mean, of the emergencies or any of the circumstances, to indirectly say that without knowing who is the patient and who is the not the patient, you should be able to take the patient along with you. That's enough to bring them a positive spirit in them. And that positive spirit is started with the words of the treating oncologist. So I am always saying that the doctor should be positive, and he should be able to convey that positivity should be conveyed to the patient. And if that is done, I think your job is done. And I think very easy to tackle a patient. That's why I said the last 30 years, I can clearly say that now I can convince a patient much more faster than what I was doing it 30 years back. The change has happened. And I don't think that you got any protocols to be followed, no modules to be selected. I think no paper should be given for it. I think it should be an open discussion. And that keeps you on a good note. Anyway, thank you. And thank you for giving an opportunity to share my thoughts, much more than it's my own experiences. Thank you.
Thank you very much, Linda, for that fine words of wisdom. It's quite, I think it's quite apt to the young minds listening to this. Over to Sparsh team.
Thank you so much, sir, for enlightening us about how to approach a newly diagnosed cancer patient. Now, I would request Dr. Subramania Iyer, sir, to kindly introduce our second guest speaker for the day.
With all your permission, may I take leave?
Sure,
Yes.
sure. Thank you very much. Thank you very much. I know.
Thank you.
Great. Now, let me take this opportunity to introduce my another good friend, Dr. Subramanian Rao. He did his MBBS from Kakinada and then MS and MS from Usmania and then MCH surgical oncology from Wow. And then he is currently the professor, head of department and director of surgical oncology services in one of the prestigious hospitals in cancer centers in Hyderabad, Indo-American, Basavataragam Cancer Hospital. More than anything, I would describe him, and I was being fortunate to introduce two great people today. One is Gangadhar and another is Dr. Subramanian Rao. Because as a person, they are all people who you should follow. You young people can have idols in front of you. And I have no doubt that Dr. Subramanian Rao is one of those persons whom you can idolize. Over to you, sir, on making of a cancer surgeon.
Are you able to see my screen?
Yeah, you can.
Subbu sir? Yeah.
Full screen. Yeah, great.
Yeah, I bow to Dhanvantari. When my elder brother, I would call him because he's a little older than me. I'm also old. Subbu Iyer called me about a week back and told me to talk something that is non-science because they're all MBBS students who want to be motivated. It should not be humorous. It could be humorous. So motivation, I always defined as a situation wherein the speaker does not have a motive of his own. He could be speaking about himself, but he should remain selfless while he's actually transmitting a message. I hope to do that today, and I hope to recruit a few youngsters into surgical oncology through this 15 minutes talk. Motivation is something that the Amrita students do not need because such a simple lady, modestly born, Amma has become her surname. Amma means everything. She's the real motivation. And if she's not available for you because she cannot meet each one of you, You have my Anna, you call him Cheta, but we call Anna. Anna is elder brother. Subbu Iyer, whom I have admired and adored over a decade now because of the tremendous commitment that he has to patients and the amount of work that he has done. This picture is viral and it says a Hindu doctor, a Christian donor, and a Muslim patient. Keeping the religion aside, I think the amount of work that he has done should motivate you, and you would not actually need too much of motivation. But for the students elsewhere, you may not have such characters to inspire. And there is enough of all this that is circulating in the social media, 14, 15 years of study and very long haul with little money. And then you have things like this where Kaikeyi asks Dasarath to send Rama to MBBS because that is a definite life imprisonment. It is much more than 14 years. The genesis of this talk is my interaction with two students. Both of them are children of my friends. One of them was 4th ranker in the country in All India Institute of Medical Sciences examination then. And in final year, he wanted to leave medicine. And the parents were crestfallen. The second one was a girl doing general surgery in CMC Vellore, brilliant girl, topper in AP entrance, topper in All India entrance. And only because the previous boss, she had already completed 25 months of her PG, only 11 months remaining. She wanted to leave because she did not like the new boss. He was a little too harsh. So such flimsy reasons, people are planning to leave final year MBBS from All India Institute of Medical Sciences and final year MS of CMC Vellore. So I thought, and then I counseled them, and what actually struck the chord with them was when I actually spoke about myself. The turbulence, the turmoil, the tribulations that I went through to become what I am and to develop this 600-bed hospital doing tremendous service. So I thought I'll extend the same thing and same ideas, and I developed this talk. Leaving the nobility of the profession alone, what it gives you is an automatic respect. People call you Dr. Saab. No, nobody else is called with any suffix like that. And it's a safe profession. At least pre-COVID time, it has been a very safe profession. And I would clearly tell you that there is no lady who is as respected as a lady doctor in this society, Indian society. And there is absolutely no dependence on anybody. You are not at mercy. You can practice. You can practice till you actually die. And there's absolutely no retirement, unlike other professions. And I don't know if you all know that it is the only profession which actually fights against the cause of its very existence. We fight disease, actually, which keeps our profession alive. So that actually adds to the nobility of our profession. In the West, getting into medicine, I can see my niece, my children of my friends. It's a huge process. They test your attitude, aptitude. It's not just NEET exam and then you select. You need to build a CV when you are a child. We write the NEET, and then if you get a rank, you start building castles, sometimes in the air. Our times, Subbu Iyer's times, who decides? Many times the father used to decide, mothers had a very little role. And the smarter among us, the father-in-law would decide because they would get married. And in Andhra, the dowries are very, very high. And the father-in-law would pay the money. The smarter ones would always think, you cannot choose a rich father, you can at least choose a rich father-in-law. I was not as smart as them. How did I choose? I was in a rural school in the hostel in the 70s, early 70s. One of those evenings, a 1-year junior child who was homesick joined just that same month, had pain in the abdomen. We thought he was trying to get back home, but he truly had pain in the abdomen. So I told my warden that this boy is struggling. Both of us took him to the hospital on a Saturday evening, and to understand that in that particular place there was only one surgeon, who is a government surgeon who had gone to Hyderabad to attend on a social function and would only return on Monday. We had no transport to ship to Hyderabad, so we stayed back. 36 hours was absolutely miserable for the child and for me because I had to keep him company. And when the doctor came at 9 o'clock on Monday, the whole hospital followed him. I was expecting a James Bond-like figure. He was short, he was diminutive, but he was impressive. He came, he palpated the abdomen and said it is appendicitis and he needs immediate surgery. Took the patient in immediately. The whole hospital followed him. And when this boy came out, he was actually sleeping for the first time. And when he woke up, I asked him, "Is that pain still there?" He told, "Some pain is there, but it's not that horrible pain of the disease." And I'm very grateful to this doctor. That day, I decided I should become a surgeon because I thought there is magic in this man for whom we waited 36 hours. And now this child is much better. I was in 7th class then. And then I also met Manu Tandon, who is chief gastroenterologist in Asian Institute of Gastroenterology now. When I was in 8th class, because I was playing for my district while he was playing for his district as a medical student, and Mode, who was also his classmate, I realized that 2 medical students are actually playing for the districts. And once you play for the districts, there's a chance that you will play zonals and then the Ranji Trophy. So I was a very keen sportsman. So I realized I can be a doctor and still be a sportsman. That was another inspiration. And why did I think about surgery? Because I didn't want to be into medicine, because I didn't want to read and remember so much. Harrison was just horrible for me. And the omnipresent Amazon also talks about it. Whoever bought Harrison also bought a ceiling fan, a 12-inch footstool, and a rope in the form of a noose. I hope you know why these things are used. And I didn't want to get anywhere there. So that actually appealed so much for me that I wanted to become a surgeon and a cancer surgeon. And I would humbly submit that if I'm talking today, it is the efforts of lots of people. And now if Subbu Iyer has called me to speak, he would have expected me to speak well enough to inspire you or influence you. I was actually a childhood stammerer. I would struggle to speak if one of my parents is not there to a new group of people. And when I was put in hostel, it was very, very difficult. And this gentleman, Brother Jose Daniel, who was the warden and the principal then, has taught me each day how to actually speak. If there was a Viva Voce in school, then I would not have cleared the school and I would have never gone to medical school. Maybe I would have become one of these famous failures, or I would not have been heard of in my life. And I also realized that there were quite a few stammerers who are extremely big people. The children at that age could be very, very cruel. One of my friends, my classmates, asked me whether I stammer always or I stammer only when I speak. I told him, I don't stammer always, I stammer only when I speak. Self-deprecating humor. And then I started speaking outside because I got married too. Because once you're married, it's very difficult to speak for long at home. So I come out, and whenever I've been invited like this, I continue to speak. After the schooling, I reached the junior college, which was like a Saraswati Mandir. The best students in erstwhile Andhra Pradesh would be brought there, completely funded by the state government. And I understood that there were so many people who were so much more brilliant than me. I had to prove myself. So I shifted to sports, which was my strength. And this gentleman who's passed away 2 months back stopped me once in the class and then told me that I could never go into a medical school with a cricket bat and a hockey stick in my hands. There was anguish and agony of a teacher. There was no animosity. I understood that. And that is the day when I started cutting down sleeping hours. I've never stopped to play to 4.5 hours per day. And till this day, 40 years now, I sleep only 4 to 4.5 hours. And then I came to Hyderabad and started playing B1 division, and then was selected to zonals, which means it is just one step away from Ranji Trophy. Azhar was a colleague then. He was playing as good as I was. But I was a good student too. And from a middle class, my father told me sports cannot be a career. There was no IPL then. So I wrote the entrance exam. This Sunday, I made 100. Next Sunday, I wrote the exam and got into a medical school. in 1982. And what immediately struck the department that scares you is anatomy, because the chance of you failing here is very high. But that was what has fascinated me. These two teachers, I remember, I would remember forever. I all understood that art of uncovering, unfolding, unfurling anatomy is surgery. So if you are a good anatomist, you generally become a good surgeon. In the old Britain, the anatomy professors and surgery professors were common, not for a simple reason. And the same professor, Geeta Rangarao, recently came to my place for her birthday, and she was refused to cut a cake unless we tell her who had actually cut the sciatic nerve. Sciatic nerve, if I remember correct, is the longest and the strongest nerve in the body. And we managed to cut it in the stretcher without even identifying it. So we told her that it was a teamwork, all of us together cut it. She laughed and cut this cake. So this teamwork has been very important in our class. All of you would understand that you need a lot of teamwork to win matches. You need a lot more teamwork to fix matches, and they are very popular for that. Life in Kakatiya Medical College was a dream run. Lots of love and affection of teachers, friends, great camaraderie, and I was a full-time sportsman, and I was a visitor to the medical school. And there were 30 girls in the class. It was just the reverse ratio of what is today, 70 boys and 30 girls. And I was in love with practically everybody, but nobody actually truly reciprocated. And I don't feel bad and sad now, because that's how they look now. It was not all rosy. One of my close friends, who was my friend since school, I had actually taken him on a tour, hockey tour. I trained him in hockey because I was mainly a hockey player. And in my hands, in Bangalore in 1984, while we were in pharmacology, he died on my lap after an accident. That is something that shook me off completely. I could not become a normal person for 6 months. I had to get back. And when I became an oncologist, there are 3 classmates of mine who died. And it's so unfortunate that these 2 died in my hospital later on, each one 14 years apart. That is a misfortune in a bundle. The dream of joining surgery was there, but I had to compete with studious colleagues. I was not a great student at all. I had a 55% aggregate, just enough to write the PGI and AIMS entrance exam. I thought we will pay 3.5 lakhs donation, but my father suffered huge financial losses, sold everything, and told me I have to get a seat on my own. So what I did was audio recorded all my notes. There were no videos then, into 120 audio cassettes, and then bought a Walkman and started hearing while I work out, while I travel, while I tour. So I was hearing to my own voice, not the best of the voices, a stammering and a stuttering voice. I'm no SP Balasubramaniam, I'm only Subramaniam. So, but still it was very sweet. And that way I got 8th rank in the state, something that inspired everybody, because a student of my caliber climbs to a place less than 10 ranks to get an MH general surgery seat. The whole campus started studying. I've inspired them one way or the other. It may be a negative inspiration. What happened then was I had a major knee injury in football. And that actually brought me down emotionally, because sports was a very important part of my life. I converted that adversity into advantage because I didn't have any other choice. I became very studious in MS, and with the effect that DK Vijay must be listening, knows then how difficult it was to get into surgical oncology. There were only 5 seats, and it was like hitting your head against a mountain. But because of this injury, I got into this. My father was not keen because cancer surgery was not very appealing then. But I thought I should choose a job I love so that I don't have to work a day in my life. Came back to practice in Hyderabad after completing in Kidwai, only to find such diseases, difficult situations, very rough terrain, rickety roads. Our professional colleagues would not understand what oncology is all about. We had lots to prove. Now, people like Subbu Iyer have made this particular branch of surgery so appealing that youngsters are running to reach there. Such reconstructions have come into existence. There were not too many images. Biomedical technology has improved so much that it's such an appealing specialty now. You can actually reconstruct a bindi, you can reconstruct a mole, you can reconstruct everything, plan perfectly and execute perfectly. So that gives you lots of happiness. What has come into existence and what has actually made me big is the minimal access revolution that has come. I understood that it is going to be very useful to patients. I approached the government. I was in government service then, but the government was not listening to the usefulness of this. So in a fit of anger, I actually applied for a loan of 20 lakh rupees and bought two full sets of instruments for the government hospital and learned laparoscopy on my own and trained a lot of people in laparoscopy. And now 7 universities in the West, all SARC nations, Gulf, African nations send their students for minimal access surgery training in our hospital. Adversity that has been converted into advantage. And there are some procedures like this, the retroperitoneal lymphadenectomy, for which we are known world over. Multiple invitations culminating in the first ASCO post from the LMIC countries. I was interviewed recently. And then at the age of 54, I had to learn robotics because it's been market driven, and for an institute of our caliber, I had to learn robotic, and that's something that I've done very effectively. I feel very happy about it. So it's all about learning, unlearning, and relearning. Yeah. Pardon?
Few more minutes.
Yeah, I'll wind up. Yes, thank you very much.
No. Yeah, just give a inspirational your part of that one.
Okay. I'll go ahead. Now, if you want to find inspiration, there is inspiration all over. Just 2 days back, what this great man has done is something that shocks you. Here, Matthew Wade had testicular cancer at 16 years, had received chemotherapy, and he's actually colorblind, and he cannot spot a pink ball properly. But this was a white ball. He hit 3 sixers and broke a few hearts, and he won many hearts. One of our patient, bilateral amputee, 70-year-old, developed epitheliomas on either side because of pressure. We needed to re-amputate, and I told him to take rest at this age, and that's what he has done. He said he would never be dependent on anybody. Fix the same processes again. He looked a little shorter, and he continued to walk. So that is the power of your patients. And if you want motivation, you must seek motivation from these people. And you want more motivation? This young girl had xeroderma pigmentosa. Subbu Iyer would be seeing these regularly. Had retinoblastomas for which radiation then was given. She lost both the eyes. And then she came with an ulcer on the tongue. It was squamous cell carcinoma of the tongue. And when we screened the neck, there was a multifocal thyroid cancer. So we did a wide excision amounting to half a tongue removal and a total thyroidectomy. And what this girl told me on the 5th day with half the tongue was that she was a ranker in 7th class. She wanted to be a ranker in 10th class, only to convince her father. She actually knew that she would not live a very long life. How can anybody be more unfortunate than this? And how can anybody have more guts and gumption than this girl? So I was a bits and pieces type of a personality. I was not the most talented at any point in time, but I've used my small qualities to really come up. If he could not play well, he became a good commentator. This man can bowl a little, bat a little, and feel a little, but now he saves more matches than anybody else. Subbu Iyer, DK Vijay, or me are personified by this child. He personifies a cancer surgeon. He's small, he's dressed poorly, like all of us. He has gone high, he has gone far, and he has gone correctly. That's what a cancer surgeon needs when you are discussing resection. And it's all about being in a huddle. We are 50 of us as a surgical team. We don't set into a huddle. We always stay in a huddle, whether there is pain or there is pleasure. And that is the hospital. That is my mail ID. If born again, I don't want to do anything different. I had my own turbulence, but I don't want to have different parents, friends, teachers, or students. Dear young ones, understand that some of you may not cross beyond MBBS. Do never call yourself just MBBS. You are a full MBBS. And please live to serve. As a doctor, it's very easy to survive, and it's so much more difficult to serve on a continuous basis. I know this would be an abrupt ending, and in the millennium, that's what is trending actually. That is Bahubali 1, and Dr. Vishal Marwa promised me that he'll give me a second chance. That will be the Bahubali, the conclusion. The interest has been created, and if you have enjoyed it, I'll come again. Thank you very much, Subbu Iyer sir, Kal Marwa, Pavitran, all of you for this opportunity.
Thank you very much. Thank you very much for that.
So we are actually, the time is lagging. My job is to introduce Dr. Pavitran. He is a graduate from Calicut Medical College, MBBS and MD, post-graduation, DM from Kidwai Memorial Institute of Oncology, Bangalore, FRCP from London, training in hematology from the Royal Hallamshire Hospital, Sheffield, UK, and gained experience in bone marrow transplantation from Fred Hutchinson Cancer Center, USA. Currently, he is professor and department head of medical oncology, Amrita Institute of Medical Sciences. To add to this, he is very punctual, always spend time to clear our doubts, even if he is very busy. When we call to get opinion regarding further management of our cases unexpectedly become malignant, he spent time to clear our doubts. I think he is very punctual and he usually come to the hospital by 7 a.m. I think so. Over to Dr. Pavitran for your speech.
Thank you, madam, for the kind introduction. Can I share my slides? Okay. So what I'm going to talk is the overview of oncology in India. Next one, can you please change? Can you please change the slide? Next one. Okay. Cancer burden in India. In India, cancer is the second leading cause of adult death in urban India and fourth leading cause of adult death in rural India. And this is also the leading cause of catastrophic health spending, distress financing, and increasing expenditure before death in India. And new cancer cases that were seen in 2020 was nearly 14 lakhs. And this is expected to be nearly 16 lakhs in 2025. And of these, more than 2/3 of patients die due to the cancer. Next one, please. So most of this, that is about 30% of the cases are because of the tobacco-related cancers. And about 15% is breast cancers, and GI cancers account for about another 20% of the cases, and uterine cancers about 5%, and lymphoid malignancies 10%, and the least common is the brain tumors. Next one, please. And as per the Global Cancer Observatory data, that is regarding India in 2020, in males, head cancer is the commonest cancer, followed by lung cancer and stomach and colorectal and GI cancers. Whereas in females, breast cancer is the commonest one, followed by cancer of the cervix. Next one. And all this data comes from cancer registries that is maintained by the National Cancer Registry in India. And there are two types of cancer registries, that is population-based cancer registry and hospital-based cancer registry. Next one. And there are about 38 population-based cancer registries. Next one. Next one, please. And 236 hospital-based cancer registries. And of these, Amrita is also part of the hospital-based cancer registry system. And we regularly send the data to the ICMR for regarding all these cancer cases. Next one. And in India, the highest cancer incidence is seen in the Aisal district in Mizoram. That is, in males, the age-adjusted incidence rate of cancer is 269.4 cases per 100,000. And in females, the age-adjusted incidence rate is 219 per 100,000. That is, in the females, highest incidence is seen in the Pabonbari district in Arunachal Pradesh. And lowest incidence is seen in the Osmanabad and Beed districts in Maharashtra. That is, in males, it is 39 cases per 100,000, and females, it is 49 cases per 100,000. Next one. This is the cancer incidence in males. You can see the highest in Aisal, that is 269. Next one. And in Thiruvananthapuram, you can see this is 137, and Kollam, it is 127 per 100,000. And is lowest in the Osmanabad and Beed in Maharashtra. Next one. And among females, the highest is in the Arunachal Pradesh, that is Pabonbari district in Arunachal, 219 per 100,000. And in Thiruvananthapuram, it is 127 per 100,000. Next one. And if they see the cumulative risk of developing cancers during their lifetime. Next one. In Kerala, you can see that the risk is 1 in 7 in Thiruvananthapuram, and among males. In Kollam also same, whereas in females it is 1 in 8 in males and 1 in 9 females. Next one. And common cancers among males are the head and neck cancers, lung, stomach, and esophagus. Whereas in females, it is a breast and cervix. This is Indian data. Next one. And if you see the data from Kerala, that is from Thiruvananthapuram, you can see that in males, again, it is head and neck cancer. If you take all the subsites together, and lung and prostate, that is a third common if you take the subsites. But in females, strikingly, breast cancer is a commonest, followed by thyroid cancer. Compared to Indian data, this is very strikingly different. That is, second common cancer among females is thyroid cancer, followed by ovary and cervix, which was the commonest in about 1 decade ago. Now it has gone to the 4th place. Next one. Next one, please. And if you see the annual percentage change of the incidence rates, you can see that among all registries, the breast cancer rates are increasing. That is, in the Aurangabad, there was a 66.8% increase. And in all the registries, you can see a significant increase in the breast cancer rates. Whereas cervical cancer rates are decreasing. This is a major relief as far as we are concerned, because vaccination is still not practiced in India commonly. So, but this is really a good thing as far as we are concerned. The numbers, definitely there is a significant decrease in the number of cervical cancer, except in the northeastern states. In Thiruvananthapuram, there was a reduction by 4.3%, and Kollam also 3.1%. Next one. The head and neck cancer, which is a major cancer in males, again, in some of the registries, there is a reduction that is happening. Especially in Kerala, there is a reduction, whereas in some other registries, the numbers are still increasing. Next one. Next one, please. In Kollam and Thiruvananthapuram, it is decreasing. And regarding the cancer centers in India, the first cancer center that was established was in Mumbai. That was the Tata Memorial Hospital in 1941. And this was followed by the first comprehensive cancer center in South India. That was the Adayar Cancer Institute. That is in 1954. And that was the second in the country. And the first comprehensive cancer center in Kerala was established in Trivandrum, that is the RCC, in 1981. And in Kochi, the first comprehensive center was established at Amrita, that is in 2003. Next one, please. Now, there are so many challenges for cancer care in India, like the health awareness or the cancer literacy, delay and limitations in the diagnosis, advanced stage of disease at presentation, healthcare financing or insurance, lack of insurance. So the insurance coverage is only about 10% of the population, and lack of cancer treatment facilities in rural areas. Majority of the treatment facilities are limited to the urban centers, and lack of trained manpower. There is a significant lack of manpower, the medical as well as the ancillary staff, and also treatment facilities. And cost of treatment is prohibitively high. So these are the major issues. And what you can see here is most of the, next one, please. Most of the cancers, next one, most of the cancers that are commonly seen, they're present in the advanced stage. That is only about less than 1/3 present in the early stage. This is localized, that's over the early stage. The lung cancer present less than 20% in the early stage. The cervix cancer present less than 30% in the early stage, whereas most of the cases present in the advanced stage, locally advanced or the metastatic stage. That is why our results are still low compared to the Western data, where they are stating about 90% cure rates, whereas our rates are still in the range of 2/3. That is about 60% only the cure rates. Next one. Next one, please. Yeah. Now the cancer care evolves around 5 treatment paradigm pillars. That is the radiotherapy, surgery, traditional chemotherapy, the precision therapy or target therapy, and immunotherapy. The radiotherapy was introduced in the 1890s, and surgery was present from the ancient times. And the chemotherapy was of these chemotherapies, the earliest branch, the youngest branch, I mean. And the first case of chemotherapy started in the 1940s. And then came the targeted therapy and of late immunotherapy. Next one, please. Next one. Next one, please. So the first chemotherapeutic agent that was used in the treatment of lymphoma was the nitrogen mustard. That is in 1943. Next one. Then came the targeted therapy. Next one, please. Next one. So the imatinib that was introduced for chronic myeloid leukemia. Previous one, please. Previous one. The imatinib was introduced in 1996 for the treatment of chronic myeloid leukemia. That was first targeted therapy that was approved, and first monoclonal antibody was approved in 1997. That heralded thereof the antibody therapy or immunotherapy. Next one. Next one, please. Now, we have all the treatment facilities like drugs, all the chemotherapy drugs, targeted agents, immunotherapy agents are all available. So also radiotherapy facilities, we have all the advanced radiotherapy systems like Linac, CyberKnife or proton therapy, and also advanced surgical facilities like robot surgery and all sorts of things. But here only limiting factor, this is as it's all well developed as compared to the Western countries. But our only limiting factor is the cost, because most of these modern treatments like targeted therapy and immunotherapy are very costly. That's the only limitation as far as we are concerned. It is not the lack of facilities. Next one. And one of the other limitation is the number of trained oncologists per population. If you compare the data with the United States, there they have 161 trained oncologists per million population, whereas as far as India is concerned, it is only 1. So this is strikingly different. In UK also, it is nearly 131 per 1 million. So we need a lot of trained personnel for the treatment of cancer cases, because the cancer cases are increasing, and so also we have to develop for the development of specialty. We need more trained people. Next one. Radiotherapy facilities also, as compared to the Western or the European countries, the radiotherapy facilities are all also very low in India. In India, for the population 1.2 billion, only 559 machines are available as per the latest data. There is only one machine, radiotherapy machine per 2.1 million people. And the recommended standard is one machine per 1,20,000. In India, in USA, it is only about 12.3 per million. And there are many career options in oncology. Next one, please. That is in the clinical, non-clinical, or the research side. There is a lot of huge, there's a demand and supply gap is huge. So there are plenty of options in clinical, non-clinical as research fields. Next one. Next one. Yeah, and there are so many PG courses or branches available in oncology, like DM, DNB, fellowships, and postdoctoral certificate courses. In medical oncology itself, there are about 131 DM seats and almost equivalent DNB seats. Then clinical hematology, pediatric oncology, radiation oncology, surgical oncology, gynec oncology, head and neck surgery, oncopathology, and also PhD programs and allied specialties like pain and palliative care and psycho-oncology. So the field is vast, and you can choose any of these for the super specialty courses. And also research, the maximum research is happening in oncology. Next one. And also career research is an option. And most of this research is happening in the basic sciences. Mostly, if you see the funding for cancer in the European Commission, about 110 million euros was spent on the cancer biology. So the majority of spending is in the basic sciences. So there is a lot of scope for basic science research also, not only clinical. Next one. Next one, please. And new drug approvals also. If you take the new drug approvals by FDA every year, this year till October 2021, there were 42 new drugs approved, and of these 18 were for oncology. So that shows the progress that is happening in oncology. Most of the new drug approvals are happening in oncology. Next one, please. So as clinicians, what you can do is you can health educate all this, your patients, whoever you are coming across. You can teach them risk reduction, like tobacco use, alcohol use, then dietary, physical activity, vaccination. And also you can advise them regarding early detection screening programs, and also health literacy and removing stigma, and all these are very important. So these are the things that you can do, at least to help or in the prevention of cancer and treatment of cancer patients. Thank you for the patient hearing.
Thank you, Professor, for your it was very interesting to note the number of availability and the number of patients. Now I am going to introduce Dr. Vijay Kumar. He is our oncosurgeon, MBBS from BJ Medical College, Pune, MSKM Hospital and BJ Medical College, Pune, MCH from Cancer Institute, Chennai. Currently, he is professor and head Department of Gynae Oncology, Amrita Institute. A very prompt and a dedicated surgeon. Usually come and see the patients before they are shifting inside the theater, before they are anesthetized. That shows his care and comfort to the
A very good evening to one and all, to all the students gathered there. I would like to thank Dr. Subramanian Rao and Dr. BPG, who spoke before me, and Dr. Pavitran for all the wonderful talks that they have given. Now, I'll be talking about breast cancer. My topic for today has been to talk about breast cancer. Now, why breast cancer? That's the first question that comes. Why is it that we have asked for breast cancer as a topic of discussion today? If you look at the global map, you can see here, this shows the incidence of cancer across, the globe, and which cancer is the highest. And almost all regions of the country, it is pink in color. If you notice, except for a few belts in Africa and South America, where the cervix is number one, all other cases, almost the globe, breast cancer is number one. So breast cancer is the commonest cancer, and this is what you will be seeing. And when you become doctors anywhere, whichever part of the globe you go to, breast cancer is something that you will be encountering. And the situation is not very different in India. Pavitra has already given you the statistics. If you look at the statistics for cancer, it is usually described as per 100,000. And in India, if you take the top 10 cancers, only 3 cancers enter the double figures. That is oral cancer in males, cervix in females, and breast cancer. And breast cancer is by far way ahead of all the other cancers. The average incidence here is 26 per 100,000. But if you look at the individual thing, the top 4, Delhi, the Chennai, Bangalore, Trivandrum, Mumbai, the metros are the ones which have the highest incidence, ranging from almost the 40s and the late 30s, where per 100,000. But India being a land of contrast, there are a lot of areas, the rural area, which have got lower incidence also. India is not a very high incidence country when you look at the global map. But what is interesting is that breast cancer is related to the Human Development Index. There are 2 maps here of the global map, if you see here. And the map on the top actually shows you where all the incidence of breast cancer is high. The dark blue color indicates high incidence of breast cancer. The lighter blue is still a little lesser. India comes in a much lower incidence category. And the graph below, the map below, shows you the area of the Human Development Index, where is the highest is dark blue, and the human index is the lowest is the red color. And these maps are almost identical if you look at both the maps, the distribution. So Human Development Index, which is actually a measure looking at life expectancy at birth, the adult literacy rate, and the income. This almost seems to correspond. So wherever there is more development, you can expect the breast cancer incidence to go high. And this is something which is true even in India. You're seeing more in the urban areas. Your state like Kerala has got a much higher incidence, possibly because the Human Development Index is higher when compared to some of the other states. There are 2 things you must look at. One is that the incidence rate, we talk of age-adjusted incidence and crude incidence. Now, the true incidence is actually the crude rate is what gives you the actual burden of disease. Actually, that means the actual number of cases is measured by the crude incidence. And when you look at the crude incidence, Trivandrum has got possibly the highest in the country when compared to the state. Whereas age-adjusted incidence is what is used to compare between population. Because Trivandrum has got a much older population, that is why the incidence of breast cancer is higher. Whereas in Delhi, which is the #1 cancer, when you look at the age-adjusted rate, it has got a much lower age population, a lot of migrant population, a lot of people coming for work, and the older age population is lesser when compared to places like Trivandrum. So the burden of disease is actually quite high in a state like Kerala. In Trivandrum is one of the highest in the country. And this burden, though India is not a very high incidence country, this burden is going to keep on increasing. You see the graph from 1982 to 2012. Everywhere in all the cancer registries across the country, whether urban or rural, the breast cancer graph is climbing slowly. So it has always been going up, and you are going to see more and more cases. And it's only a matter of time before we also come into the high incidence countries this thing in across the world. So I change track here and look at how do we manage breast cancer. See, it's a very common disease, and you are going to see breast cancer. Now, as you come out of practice into practice, whatever branch you choose, you will definitely come across breast cancer because it is that common. I see about 8 to 10 new cases every day in my OPD every day. But during my student days, when I was an MBBS student, when I was a postgraduate student, the management of breast cancer was much simpler. It was just radical surgery and some adjuvant treatment. You know, it started with radical mastectomy, which was a very radical surgery, a disabling surgery where you took the entire skin over the breast, all the muscles underneath, the pectoralis major, the pectoralis minor, and it left a very debilitating scar. The complete axillary dissection was done right up to level 3. And radiation was given for those which are locally advanced. The systemic treatment, you know, when I was studying in most of my MBBS and during my post-graduation days, the systemic treatment was very simple. We didn't have much systemic treatment. If a breast cancer was node negative, they received no further treatment. If it was node positive, the treatment was based on the menopausal status. That means a premenopausal age received some chemotherapy, that is a CMF chemotherapy then, and a postmenopausal patient received tamoxifen. So the treatment was simple. Everyone underwent surgery. After surgery, if they were node negative, no further treatment. If they were node positive, they received either tamoxifen or CMF chemotherapy based on their menopausal status. So the treatment, if you look at the past, has been surgery dominant. You know, initially you just did, we had only FNAC then, or in some cases the incision biopsy. If FNAC was not available, you did a mastectomy with wide margins. It started with radical mastectomy, but then became modified radical mastectomy with various modifications where the muscles were not removed and whether sometimes only the minor was removed. And axillary clearance was almost always up to level 3. If there was node positive, if there was locally advanced in the form of skin or chest wall invasion, we gave local radiotherapy. And as I said before, it was tamoxifen only for postmenopausal group and CMF chemotherapy for premenopausal group. But even in metastatic breast cancer, we used to go surgery dominated. We used to go local surgery in the form of a toilet mastectomy to remove the ulcerating tumor sometimes. And even for the treatment of metastasis, I have assisted in a lot of cases where we did oophorectomy as a treatment, and we did adrenalectomy then as a surgical choice for metastatectomy and hypophysectomy. I even assisted in 2 cases for hypophysectomy then for metastatic breast cancer. So this used to be, you know, for everything we had a surgical option long back. Now a lot of things have changed after that because we realized that even if we did very aggressive surgery, we did not cure all patients. You know, in node negative patients, still about 30% develop metastasis, whereas in node positive patient, almost 50 to 60% develop metastasis. So you may do a very aggressive, very radical surgery, but you are still going to lose the patient because of metastasis. So this became the stimulus for development of more effective systemic treatment. So we started looking at better systemic treatment. Newer chemotherapeutic agents had come in by that time. We started looking at anthracyclines and the taxanes. And so a lot of newer agents came. But whom to give these agents? The next question was, whom should you know, how do we decide who gets the more aggressive chemotherapy and who does not? Does everybody need it? Because we know not everyone fails. You know, only 30% of the node negative fail. So who are those 30%? How do we identify them? And that is where the role of the pathologist became very important. The pathologist, we started looking at the pathology much more closely. So the lymph node status was the first thing we know. If the lymph nodes are positive, definitely the chances of failure was higher, so they would require systemic treatment. Then we looked at the tumor size, simple thing like a tumor size. The larger the tumor, yes, the more chances. Similarly, if there was lymphatic or vascular invasion, if there was a higher grade tumor, the grade was high, or if there was some subtypes, the histological subtype, you had favorable and unfavorable subtypes. The metaplastic carcinoma was an unfavorable subtype, a papillary mucinous or tubular was a favorable subtype. So depending on the histologic subtype, the other thing that we looked at was the proliferation rate. That means if there's a very highly proliferating tumor, the chances of failure are more. So they require more aggressive treatment as against those with proliferation. Those times used to be measured either by mitotic index, counting the number of mitoses, or looking at the Ki67 later, much later. And another factor which we looked at was the hormone receptor status. So all these things helped us to decide, who wanted treatment, who should not get treatment. So suppose a patient did not have lymph node, was a smaller tumor size, did not have lymphovascular invasion, was grade 1, was a favorable subtype histologically like papillary or mucinous, the proliferation rate was low, then those patients did not need any adjuvant treatment, did not need systemic treatment. Surgery alone may be curative for them. So these came to be called the prognostic factors. So basically, when you say prognostic factors, you want to look at factors which help you decide who will need more aggressive treatment, who needs less treatment, and where you stop the treatment, So how did we start then? The management was first you confirm the diagnosis of a breast cancer and stage the disease. For this, you need a core needle biopsy because you needed a biopsy which is preferably image guided. You would look at the histology, you would look at the grade, you would look at the immunohistochemistry with estrogen receptor, the progesterone receptor, and later the HER2 receptor, that is the human epidermal growth factor receptor, and the proliferative index which was measured by the Ki67. Metastatic workup was done only if there was no positive disease or if it is locally advanced or if the patient was symptomatic, if for some metastasis like bone pain or anorexia or cough. Otherwise, if a node negative early breast cancer, metastatic workup was not really needed. So once we had the diagnosis of breast cancer, the next step is to stage the disease, and the staging was always then was the TNM staging. That means the tumor size, the nodal status, and the metastasis. So this, based on the tumor size, based on the nodal status, we could group it. It was stage 1 to stage 4. If it was M1, it was stage 4. Whereas the T1 and 0 was always stage 1A in the older edition of AJCC. This thing. So the traditional classification was simple. Once you have a breast cancer, based on once you have the diagnosis and you stage it, based on the stage, you call it either early breast cancer, which is T1, T2, N0, N1, or you call it locally advanced breast cancer when it is T3, T4, N2, or N3, and your metastatic breast cancer if it is M1. The treatment also followed a similar routine. That means if it is early breast cancer, you could do, there's a very low incidence of metastasis. So breast conservation is possible. You may not need very aggressive systemic therapy. Sentinel node is possible in the N0 group. Whereas locally advanced breast cancer, usually metastatic workup is needed. You may prefer neoadjuvant treatment. That means you don't go for surgery upfront, but you treat with chemotherapy first and then go for surgery. And breast conservation surgery was only occasionally done. Whereas in metastatic breast cancer, the predominant role became that of chemo or hormonal therapy, and with some role for surgery in limited situations only. But then in the early 2000s came the molecular classification. There's a lot of advances in the molecular technology. So that the microarray, which came in a big way, in which you could actually identify which genes were overexpressed in a cell, which genes were underexpressed in a cell. And once you had this microarray, in 2005, I think it was the first time that the breast cancer, when they looked at a lot of breast cancer, because of the newer technology, you could do a lot of cases in a small slide, you could identify. And breast cancer came to be actually classified into a different way now. From the earlier traditional early breast cancer to locally advanced breast cancer, you now classify it based on the gene expression status into luminal A, luminal B, HER2/neu, and basal. That means depending on which genes are overexpressed, the estrogen receptor genes, the HER2 gene, or based on these things, you could classify breast cancer into these 4 categories. There are a few more categories being added now, based on more and more newer genomic assays being newer genes being detected. But this was done by the microarray technology, and microarray is not possible to do microarray in each and every case. So you needed something. Now, whenever a gene is overexpressed, there is a corresponding overexpression of the protein which it represents. So if the estrogen gene is overexpressed, the estrogen receptor will be overexpressed in the cell. So you looked at surrogate markers in a simpler way. So the luminal A, luminal B, HER2, and basal like, or the triple negative, as it is called, it could be now classified with surrogate immunohistochemistry as a surrogate marker. So if you had a IHC was done on every specimen, you looked at the ER, PR, HER2/neu, and the Ki67, and based on this grouping, you classified them into a luminal A or luminal B if they are ER positive, and if it's a high proliferating index, it becomes luminal B. It becomes luminal B. Whereas if the HER2 is overexpressed, it becomes that is a human epidermal growth factor receptors. It becomes HER2 positive, and whereas the ER/PR HER2 negative with the expression of the high molecular weight cytokeratin like CK5 and 6 and EGFR becomes a basal-like. So this became the new norm of how do you look at a breast cancer now. Today you don't look at breast cancer as early and locally advanced only, but you look at it what is the biology of the tumor. Whereas luminal is considered a favorable biology and HER2 and basal-like considered an unfavorable biology. And this is reflected in the new TNM staging, which was reflected in 2017, which has incorporated all these things. Now, today, TNM is not just tumor size and node and metastasis. You look at the prognostic factors also. That means the TNM includes the grade, the ER, the PR, the HER2/neu, and even additional factors like the genomic scores, like the Oncotype DX score, and a few more which may get added soon in the near future. So now, see, previously when T1, N0, M0 was always stage 1A. Even now it is stage 1A if it is grade 1 and ER positive. But you can look at the next slide. Again, the T1, same T1, N0, M0, if it is triple negative or if it is grade 3 can become stage 2A. So the same T1, N0, M0, which was stage 1A always in the previous, now can be either 1A or can be 2A. Similarly, you realize that the outcome of breast cancer treatment will depend more on this biology rather than on the just the anatomical staging. So what do we do today when we have a breast cancer cases? If it is a node negative, clinically and radiologically, then we prefer surgery upfront. If it is node positive, then biology decides. And the surgery today is much more changed a lot, where we go more for conservation, we go more for oncoplastic surgery, organ preservation is the rule. Sentinel node is very commonly done, and it has to be done in all cases who are node negative so that we decrease the morbidity. But if it is node positive, then it depends on the biology. If it's a bad biology, we prefer always neoadjuvant therapy, neoadjuvant chemotherapy. If it's a favorable biology, we can go for primary surgery, or we can even go for neoadjuvant hormone therapy if it is locally advanced. So basically today, when we look at breast cancer, when you step into the practice as new doctors, you should know that breast cancer today will be classified by either the basal, the HER2 or the HER2 overexpressed luminal and A and luminal B. And the treatment is essentially that. That means the basal one, you will see the chemotherapy predominates. And as you go down the ladder, it is more of endocrine therapy. Luminal A, it's almost predominantly endocrine therapy. Whereas in the luminal HER2 enriched ones, you need anti-HER2 therapy. That means you do antibodies against the human epidermal growth factor receptor. Trastuzumab being the first one which you start, but there are many more which come. There are various other agents now being in the targeted therapies like PARP inhibitors, which are very commonly used in the triple negative or the basal type. You have angiogenesis inhibitors, which are not so commonly used now. Stem cell inhibitors, which are still very much experimental stage. But overall, you must remember that the basal and the HER2 positive are considered poorer prognosis, whereas the luminal ones are considered as a good prognostic group. And what you're going to look at now is today is more and more of newer targeted therapies. You know, there are newer agents, the CDK inhibitors in the luminal types. You look at the CDK inhibitors like palbociclib, ribociclib, abemaciclib, which have all come now into use regularly, especially the metastatic breast setting. And today you can, patients of metastatic breast cancer can live for many, many years, 10, 15, 20 years also sometimes on these medicines, newer targeted therapies. In the HER2, you have a whole host of newer agents, the trastuzumab, pertuzumab, tucatinib, lapatinib, neratinib, and a whole lot of them which are all being used, are regularly available now. And in the triple negative is where there's a lot of research going on, a lot of use of immunotherapy, which is something which is really revolutionized a lot of management in the triple negative, which we didn't have many targets before. PARP inhibitors like olaparib and talazoparib is again something which is coming up in a big way, especially those who are the BRCA mutation. That means there is a mutation in the BRCA gene which leads to breast cancer. So there are a lot of advances happening. It's a happening field, the case of breast cancer. And you must remember that as you step into practice, as students, when you step into practice today, the surgery of a breast cancer is more and more conservative. You know, with organ preservation of the primary, it is always breast cancer conserving surgery and oncoplasty. or primary reconstruction. Even if you have to do mastectomy, you always offer primary reconstruction. Even the axillary surgery morbidity has been decreased with the use of sentinel node, targeted axillary dissection, and sometimes even no surgery at all to the axilla, only radiation to the axilla. So in radiotherapy, we have become more and more focused. The quality of radiation has improved so much today that you can give over a shorter and shorter duration. Hypofractionation. Initially, we used to give 5 weeks of radiation. Today, it become 3 weeks. And today, there are good studies which show that even 1 week and 2 weeks of radiation may be enough to for effectively. You have partial breast radiation, that is AP, accelerated partial breast radiation. And even in oligomets, is a condition previously metastatic disease was always considered uncurable. Today, we are talking of cure in oligometastatic cases. And this is where a stereotactic body radiotherapy, the use of cyber knife, things like that become very useful. And we are today talking of curing patients even with metastasis in breast cancer. In the systemic treatment, though we have a lot of targeted therapy, what we must remember is the stress today is on doing genomic profiling. You look at the individual, I mean, it's a personalized treatment. Each patient requires a different treatment. So today we need a tumor test sample to do a genomic profiling of the individual tumors, and then that will help you decide which treatment the patient goes for. It's not one size fits all type of treatment. So there's a lot of changes happening, and I'm sure that all of you who step into practice soon this will become very familiar with all these in the very near future. Thank you. Thank you once and all.
Thank you, Vijay, for your elaborate and in-depth details about the carcinoma of the breast. We are seeing breast even in the younger age group from 25 years onwards. And as a gynecologist, it is our responsibility also to see the young reproductive age group and perimenopause patients when come to the other gynae complaints. We have a responsibility to palpate the breast and to see whether any undetected mass is there, so that we can direct them to attend the appropriate person to get the appropriate treatment. Thank you.
Thank you, ma'am. Now, I would request Dr. Mala Mathur Sharma to introduce our next speaker for this session, Dr. Pradeep Jacob.
Thank you, everybody, and thank you, Sparsh, for inviting me on this session. It's an excellent get-together for all of us. I am going to introduce Dr. Pradeep Jacob. I'm so happy and so fortunate to be able to introduce him. He's a very, very dear friend, colleague, an excellent clinician, and a very, very fine human being. As all of us know, you all students, Department of Surgery, all residents, we are so lucky to have him with us and to have him as our HOD and also to have him today with us giving this talk. He is a graduate and postgraduate from Kotia Medical College, and currently he is the professor and head of the Department of Surgery, and he will be giving a talk on thyroid malignancies. So over to you, Dr. Pradeep, and we are so fortunate to have you today with us for this talk.
Good evening. Greetings to all the student delegates from Amrita, other parts of India, and across the globe. So I'll be talking today about thyroid malignancies. This is a topic very close to my heart. How do I switch slides? Thyroid malignancies, these are the most common endocrine tumors. And if you look at thyroid nodules coming across to the clinic, 5% of all thyroid nodules are malignant. Figures across the world, you have an annual incidence of about 0.5 to 10 per 1 lakh person. The highest global incidence is recorded in North America. You have a female to male ratio of 3:1. If you come closer to home, you find that in India, the highest crude incidence rate is among females in Kerala. As all of you are familiar, the thyroid malignancies, majority of them are primary malignancies. They're from the follicular epithelium. You have the follicular carcinoma and the papillary carcinoma. The other differentiated thyroid cancers. And the poorly differentiated thyroid cancer, you have the anaplastic carcinoma. From the parafollicular C cells, you have the medullary carcinoma. You have the lymphoma of the thyroid. And you may have metastatic deposits in the thyroid, commonly from the colon, kidney, and breast. So talking to a diverse subset of students, I'm told that we have students across from first MBBS all the way to final MBBS. It's a little challenging as to how far I should go. So I thought do a little bit of vertical integration. This is the magic word these days. So we'll start all the way from anatomy, right? For the first years, you've been taught that the thyroid has two lobes and an isthmus, a pyramidal lobe in 30% of individuals. Why is this important? Because when we do surgery on the thyroid for thyroid malignancies, we have an option of removing both the lobes along with the pyramidal lobe. This is what we call a total thyroidectomy. Or we may remove just one lobe, what we call a lobectomy, or the lobe with the isthmus, a hemithyroidectomy, right? And you have learned that there are a lot of important structures in close relation to the thyroid. You need to know about the recurrent laryngeal nerve, the external branch of the superior laryngeal nerve. These are very important as far as the voice of the patient is concerned. So we need to identify these nerves, preserve these nerves while doing a safe thyroid surgery in thyroid cancers. The parathyroids, which are responsible for your calcium homeostasis, 4 in number usually, we make attempts to identify these parathyroids during surgery. The lymphatic drainage of the thyroid, this is again very important because many malignancies of the thyroid spread via lymphatic. So you need to know which lymph nodes the malignancy would spread to, and we need to focus our attention on what we call the central compartment nodes, the prelaryngeal, pretracheal nodes, the perithyroidal nodes, and from there it may go to the lateral neck nodes, right? The level 2, level 3, level 4, and rarely level 5 nodes. So this is why you've been taught about the thyroid during your anatomy classes. And physiology, we need to know about the steps of thyroid hormone synthesis, how iodide is trapped, how iodide gets oxidized to iodine, how it combines with tyrosine, then coupling of monoiodotyrosine and diiodotyrosine to form T3 and T4. Need to know the role of iodine in thyroid hormone synthesis, the role of TSH, thyroglobulin. All of this you will come to know plays a very important role in the management of thyroid malignancies. We have hypothalamus pituitary thyroid axis that you're all familiar with. And you know that there is a negative feedback. And this negative feedback is something that we utilize in management because differentiated thyroid cancers are TSH dependent tumors. And if you keep the TSH low, you can keep the disease under control. So that is why we give a higher than usual dose of thyroxine after a total thyroidectomy so that the TSH is kept suppressed. So we have a application for what you're learning in the initial years when you start practicing medicine. Biochemistry is not to be left behind. We need to know about the levels of hormones, the thyroid hormone levels, the normal levels, TSH, thyroglobulin, antithyroglobulin antibodies. When you come to medullary carcinoma, the role of calcitonin, CEA, all of this is important. Pharmacology, you find that after thyroid surgery, we'll have to replace thyroid hormone. So levothyroxine is given either as a replacement dose, or in TSH dependent tumors, we give a suppressive dose of levothyroxine. Recombinant TSH is something that has come up recently, where you can give recombinant TSH before radioiodine uptake scans, and the role of tyrosine kinase inhibitors in advanced tumors. These are just some of the drugs that are used in the management of thyroid malignancies. So why do some patients develop thyroid cancers? What is the etiology? Right? If you look at papillary thyroid carcinoma, radiation in the childhood is a very important predisposing factor. And you find, if you look at that picture there, that is 1986, Chernobyl nuclear disaster. Right? And you look at the number of children that have been exposed during that unfortunate incident, and the huge number of papillary thyroid cancers that developed maybe 10 or 15 years after 1986. So that just underlines the importance of radiation exposure. In the past, radiation used to be given for benign problems like tonsillitis, acne vulgaris. All of this used to predispose those unfortunate children to papillary thyroid cancers. Follicular thyroid carcinomas may develop in long-standing multinodular goiters. Chronic lymphocytic thyroiditis, you see lymphomas. Hashimoto's thyroiditis, you find may go on to form papillary thyroid cancers. And if you look at the age, you find that papillary thyroid carcinomas usually are seen in the 3rd and 4th decade. Medullary thyroid carcinomas in slightly older patients, and anaplastic carcinoma usually peaks by around the 7th to 8th decade. There are several familial cancer syndromes in which you can see thyroid cancers, Cowden syndrome, FAP, Werner syndrome, to mention a few. And medullary thyroid cancers can be seen in an entity called MEN. So that is multiple endocrine neoplasias. So in MEN2A, in addition to medullary thyroid cancers, you'll see pheochromocytomas and hyperparathyroidism. MEN2B, you will have mucosal neuromas in addition to medullary thyroid cancers and pheochromocytomas. There's several genes that are implicated in thyroid tumorigenesis. You have the RET oncogene, the BRAF mutations, P53 tumor suppressor genes. So these are some of the genes that can be implicated in thyroid malignancies. So as we work our way up, we are now reached pathology. And these are some things that you will come across when you look at the microscopy in thyroid cancers. Papillary thyroid cancers, you'll have Samoma bodies, that cartoon character that you see there, the orphan eye nuclei, the nuclear grooves. These are characteristic features that help you diagnose papillary thyroid cancer. There are certain aggressive variants of papillary carcinoma. These are the tall cell variant, the diffuse sclerosing variant, columnar cell variants. And coming to follicular carcinomas, you have the typical capsular invasion and the vascular invasion, which help us in diagnosing a follicular carcinoma. Medullary carcinoma thyroid, usually identified by its characteristic amyloid stroma. And this is a slide of anaplastic carcinoma. Thyroid lymphomas are usually non-Hodgkin B-cell lymphomas, and they commonly arise in chronic lymphocytic thyroiditis. So how do these patients present? So now we've come to the clinical side. You've reached the 3rd MBBS, and you're started your posting in surgery, and you're attending your clinics along with the consultant, and you see a patient coming in with a thyroid cancer. So how do they present? So they may present with a thyroid nodule, might be confined to one lobe, might be there in the opposite lobe as well. Many of these malignancies present as enlarged cervical lymph nodes, or they may come with hoarseness of voice, which indicates that the tumor has infiltrated or affected the recurrent laryngeal nerve. in many patients, when you palpate for the carotid pulse, you find that the carotid pulse would be absent on one side. This shows that the carotid sheath has been infiltrated. So that's a positive Berry sign. Anaplastic carcinoma, usually rapidly increasing thyroid swelling, hard, local fixity, and some of these tumors spread via bloodstream and present with distant metastasis. One of the characteristic features of secondaries from a follicular carcinoma is a pulsatile skull mets. It's just a couple of pictures. That's a picture of anaplastic carcinoma presenting with airway issues, for which the airway had to be secured. And the on the right, you see a patient with a follicular carcinoma with a pulsatile skull mets. You can see on the X-ray the lytic lesion in the skull. So every clinical diagnosis needs to be confirmed by investigations. And one of the most important tools that we have at our disposal is the FNAC. It's safe, it's minimally invasive, but with USG guidance, we find that the accuracy of FNAC can be increased. One of the major limitations as far as thyroid cancers are concerned is that an FNAC is unable to differentiate between a follicular adenoma and a follicular carcinoma. The pathologist will tell you that it's a follicular neoplasm, but unless they demonstrate capsular invasion and vascular invasion on a biopsy, they'll not be able to tell you whether it's an adenoma or a carcinoma. This is the Bethesda classification system for interpreting the FNAC in thyroid malignancies. The next commonly available investigation is ultrasound. So it's highly sensitive for thyroid nodules. It can pick up small thyroid nodules. And there are certain features on an ultrasound that lead you to suspect a malignancy. Hypoechoic lesions, which are taller than wider, microcalcifications, chaotic vascularity within the nodule, presence of cervical lymph nodes, enlarged cervical lymph nodes with loss of fatty hilum and microcalcification. So these are some of the points in an ultrasound that can help us diagnose that the nodule is likely to be malignant. And we go with the TIRADS classification, where TIRADS 5 indicates a highly suspicious nodule. X-rays may help in detecting a pulmonary met or a lytic lesion in the skull in a case of follicular carcinoma. CT or an MRI might be useful in evaluating local infiltration, the trachea, the carotids, the esophagus, and also nodal metastasis, and if there is mediastinal extension. That's an X-ray showing a lytic lesion in a patient with a follicular carcinoma. Role of blood investigations, laboratory investigations are usually with medullary carcinoma, where serum calcitonin level or a pentagastrin stimulated calcitonin level can help us diagnose a medullary carcinoma thyroid. CEAs are usually elevated in medullary carcinomas. We can do PCR assays for germline mutation in red proto-oncogene for familial medullary thyroid carcinomas. Like I mentioned, medullary carcinomas may be associated with pheochromocytomas, and to diagnose a pheochromocytoma, we would measure the urinary VMAs, the metanephrines and catecholamines. So once we've made a diagnosis, then we need to decide on treatment strategies. At an undergraduate level, I don't think we need to complicate things. If we have a biopsy proven, FNA proven thyroid malignancy, the usual treatment would be total thyroidectomy. If in a papillary carcinoma, total thyroidectomy, the central compartment nodes are involved, we would do a central compartment neck dissection. There is no role for a prophylactic lateral neck dissection in papillary thyroid cancer. If the cervical lymph nodes are involved, then we would do a selective node dissection, focusing mainly on level 3 and level 4, and some cases of level 2, and occasionally level 5, but limit yourself mainly to level 2, 3, and 4. Recent literature points towards option of doing a hemithyroidectomy in patients with low risk differentiated thyroid cancer. We have several risk stratification scoring systems available, the MACEs, the AGES, the AMIS. And this can help us decide on whether the patient is a high risk or a low risk. In follicular carcinoma also, the primary treatment would be a total thyroidectomy. And after a total thyroidectomy, like I told you, these differentiated thyroid cancers are TSH dependent tumors. So we will give a suppressive dose of thyroxine so as to keep the TSH at the lower limit of normal, around 0.1 microunits per liter. For medullary thyroid cancer, the treatment is a little more complicated. If it is confined to the neck, we'll do a total thyroidectomy with prophylactic central compartment node dissection. We usually tend to go a little more aggressive with medullary thyroid cancer, and if there is any sign of lateral node involvement, we would do a modified radical neck dissection, usually bilateral. And in patients with MEN, if they have a pheochromocytoma, we operate on the pheochromocytoma first and later on the thyroid. If the tumor is unresectable, tumor debulking can be done. There is a role for external beam radiation. Tyrosine kinase inhibitors can be used. And what is important, especially in the familial medullary thyroid cancer, is to screen all the patient's relatives. And if they have the genetic underlying genetic markers, then we offer a prophylactic thyroidectomy for the relatives. Anaplastic thyroid cancers are usually very advanced at presentation, but if they are resectable, you still need to go ahead with a total thyroidectomy followed by chemoradiation. If they are not resectable, usually they present with airway compromise, and to free the airway, we may do a isthmusectomy. But if it is not resectable, then role of external beam radiotherapy and targeted therapy. Lymphomas, like any other lymphomas, the mainstay of treatment for thyroid lymphomas would also be chemotherapy, usually the CHOP regime. Radiotherapy may also be given. So having done the surgery, how do we follow up these patients? Then we come to thyroglobulin. Thyroglobulin is an important tumor marker for differentiated thyroid cancers. So when you monitor the thyroglobulin serially, if you find that there is an increasing trend in the thyroglobulin, it tells you that there is either a local recurrence in the thyroid bed, or there is a nodal disease, or there is a distant metastasis. So when you measure thyroglobulin, we also need to measure thyroglobulin antibodies along with it, and usually measured at 6 monthly intervals. Immediately after the surgery, we would do a radioiodine uptake scan to see whether there is any residual disease. And before we do a radioiodine uptake scan, the patient needs to be on an iodine-free diet for a period of 3 to 4 weeks. They are not started on thyroxine so that you push up the TSH, and this is where recombinant TSH can be used. And the other imaging modalities that we use are cervical ultrasound, again to look for recurrence or residual disease in the thyroid bed, and for nodal disease. Certain cases, we may need FDG PET scan, especially if in what we call a tennis syndrome, where the thyroglobulin is elevated, but the iodine scan is negative. Medullary thyroid cancer follow-up is with serial monitoring of calcitonin and CEA with imaging, ultrasound, CT, MRI, or PET scan. And once you find a recurrence, the best treatment would be surgery if it is feasible. But if not surgically resectable, then we can go ahead with I-131 radio ablation or external beam radiotherapy. So this was very briefly about how we go about managing thyroid malignancies. I hope I made myself clear. If you have any other doubts, please put it up in the chat box. We will try and get back to you with that.
Thank you, Dr. Pradeep. It was an excellent talk and such a vast topic of thyroid malignancies you have covered up in one small this thing. This was really like very difficult task, but you've done it and summarized it beautifully for the undergraduates. For the next talk, I would like to introduce my very dear friend and colleague, Dr. Wesley Jose. He's a medical oncologist working with us, and I have a great admiration because of his clinical approach and his decision making thoughts. And I have had very beautiful interactions with him, and he is an excellent way with in-patient communication and also excellent way in surgeon communication with the surgeons, which is very important in oncology. So, that to discuss and you to convince the surgeons that yes, this is the required. So, I really have a great admiration for him, and he's a graduate and postgraduate of Christian Medical College, Ludhiana, and he has done his DNB at Amrita Institute, Cochin, and followed by MNAMS, and he is now professor in Department of Medical Oncology, Amrita Institute of Science. And I would like to request Dr. Wesley to come up to the forum and give us a beautiful talk on lymphoma.
And I am from Medical Oncology Department at Amrita, and it is definitely a privilege to talk to you and give you a small bird's eye view of how I managed to end up here and whether I'm really enjoying it. I'm told that the reason why we are doing this is to make sure that all of you as youngsters, as young medical budding professionals, would have a clarity on what you're going to achieve in the next decade or so. I would have been really privileged if this sort of a thing would have happened at a time when I was young, but somehow that hasn't happened, and definitely I consider myself very glad and very happy and very privileged to be actually talking to you about a topic which is of so much of relevance, and I'm proud that the students today are thinking way beyond what we could do in our times. This is my alma mater. It is the Christian Medical College in Ludhiana. It's a 125 years old institute as of 2019. When I reached this place, I was met with a very happy smiling face of this gentleman. His name is Dr. Alex Zachariah. He was probably the first person who started a medical oncology department in CMC Ludhiana, which was the first of its kind in the entire North India. He was trained in Indianapolis from 1969 to 72, and when I reached this place, he was the principal of the college. A very soft-spoken, very gentle person. He asked me quite a few things in my interview and asked me what I wanted to be, and I looked at him, I stared at him, I had no clue what I wanted to be. But in that process, he probably saw something which made him use me up in certain other areas of college activities, and then I realized that this gentleman was also an oncologist. I had a few opportunities to actually go with him, look at the wards, and that was a pathetic sight. I always wondered how somebody of his stature would have the time and the passion to go after things which seems to be absolutely a waste of time. But I have actually seen him go and hold hands and talk to these people in the Department of Oncology in the wards and realized that it was something different. It was not something that I would definitely want to do in my life. But that thought of him holding the patient's hands who were quite sick really stayed on with me for a long time, even to the time when I was finishing my MBBS and moving on, though I never had the opportunity to go back again into those cancer wards. At that point in time, my understanding of oncology was what Harrison told us. This is the picture of the book that I read in my time. This was 11th edition, and I think some of my colleagues and my seniors who are sitting here probably would have read books even prior to this. At that point in time, there were barely 14 pages that was dedicated to the entire oncology. And in those 14 pages, what was written was barely anything that I would want to do in future. Now, thankfully, with the newer editions, the 20th edition that you have in hand, about 400 pages of oncology is there, but still, some of the chapters are barely 5 to 6, which doesn't really give you an in-depth understanding of what oncology is about. And somehow we have failed in our teaching, where oncology seems to be something that we don't really appreciate, or we don't really want to teach our students. And these are not things that you see in your regular routine rounds in your medicine wards. And even if it is, you probably would just skip those bits. A few years down the line, I would just fast forward to 10 years of my career. And then sometime in the early 2000s, when I did my MD, I was called upon by my chief, and he looked at me and he said, I would like you to meet somebody, and I would like you to put some effort into developing the oncology department in CMC. I was taken aback, but that was something which was quite meaningful to me, because it was definitely my boss in my head who was calling me and asking me to do something like this. But I also realized that I had absolutely no clue, and my best idea of oncology was what I had seen about 10 years ago, and that picture in my mind was so pathetic and so uncomfortable that I was not sure whether I was taking the right step. But destiny be it, I decided on just taking his option and proceeding with it. To help me out, he introduced me to this gentleman. His name was Dr. Seva Singh Lega. He was a CMC alumnus, quite a senior person. He looked like a grandfatherly figure. So I did not kind of get scared of the idea of working in oncology, because this gentleman was so pleasing and so nice to talk to. I had no clue as to who he was, except the fact that he was a graduate from CMC. Only much later I realized he was a big guy. He was a professor of medicine and medical oncology. He was the head of melanoma section. He was in the University of Texas MD Anderson Cancer Center. And he was attributed as the person who developed the melanoma protocol, which is also known as Lega protocol or the MAID protocol. To be under his tutelage for almost 7 or 8 years was an extremely wonderful opportunity. And I would probably lay a lot of my interest in oncology to this gentleman, who, with his very calm demeanor, actually took me and made me read through things and understand oncology from a different perspective altogether. The initial 2 years was excellent, and then we learned quite a few things, managed quite a few things together. And one fine morning, he called me and asked me, "Wesley, are you comfortable treating a patient with peanut?" I said, "Sir, peanut, coconut, whatever nut you want, I can treat as long as you're helping me out." He laughed, I laughed, and then we did a few things. The truth was, I had absolutely no clue of what a peanut actually was. It didn't make any difference to me, because I knew if I mess up, this gentleman is right behind me to help me out. Thankfully, my colleagues today, my friends here today, have invited me to talk about lymphoma and not actually peanut or coconuts, which is something that I'm happy about, and also feel that I do know something about lymphoma, which I can probably teach you. Lymphoma is, unlike all the other things, actually a joy of oncology. We somehow feel very excited and happy when a patient walks in with a diagnosis of lymphoma, rather than brain tumor or some sarcoma or some bone tumor, which are treatable, curable, but at the same time quite difficult to manage. Lymphoma somehow, on the other hand, are very happy ending stories. So lymphoma is something that has been asked of me, and for today, to make it simple and straight to all of you, I would try and put it across in form of 3 parallel stories. I know if I talk about lymphoma in its pure scientific terms, the next 10 minutes are going to be hell for you, which I definitely don't want to. I want you to carry this memory with you, so that you would be able to make a few decisions in your life based on what you hear today. So to make it simple and clear, I have picked up 3 of my patients who all had the same diagnosis, but they all went through different ways, and they have all ended up with different outcomes. My first patient was a 19-year-old girl who was an engineering student. The second person was a 39-year-old male who was a foreman in an offshore oil drill in the Middle East. The third person was a 72-year-old male, a retired banker. Looking at these 3 patients, you would realize that unlike all the other specialties, oncology is something that deals with every age group, every gender. Whether you are a pediatric kid with an oncology problem, or you are a geriatric person with an oncology problem, you end up in the same department. So most of us who want to be a pediatrician or a nephrologist or a cardiologist would finally end up in areas which are niche. Most of your patients would belong to a certain category or certain group. Whereas when you come to oncology, it's a wide open field where you would get all kind of patients, all sort of people together who come and meet you up to get their problems solved. Now, the first girl that we had, the 19-year-old girl who was an engineering student, came to us with complaints of persistent cough, chest discomfort, and feeling of shortness of breath, and this has been going on for 6 months. The second person, the 39-year-old male, came to us with headache, abnormal behavior, visual disturbances, and 2 episodes of loss of consciousness, which happened over 2 months period. He was on his drilling field when this happened, and his friends put him on a plane and sent him back home to get treated. The third person, the 72-year-old gentleman, a banker, came to us with progressive abdominal pain and distension, bowel issues, and fever, which was going on for 1 year. Now you realize that all these 3 patients have come to you with entirely different set of symptoms. Now, if you want to practice medicine, unlike surgery, medicine is a spy game. You really need to figure out what is happening by looking at all the clues that you have and try and figure out what could be the most likely diagnosis in this patient. You make a good diagnostician, you make a good physician. You need to understand that it is not all about scans and tests. It's about touching a patient, talking to them, finding out what their problems are in real life, and trying to understand, put those things together and trying to understand whether you would be able to get to a diagnosis with the minimal means you would be able to actually diagnose this person and carry them forward. So obviously the 19-year-old girl had gone to multiple doctors in the 6 months period and found multiple diagnoses, including tuberculosis and pneumonia and sarcoidosis, and all these things were differently worked up. She was treated. 6 months later, she did not feel better, and she landed up with us. This gentleman who was on for 2 months did not go to any doctor. He self-treated himself because headache is something that's not a big deal. Visual disturbances, you always blame it on your failing eyes. Abnormal behavior, obviously I can't make out that I am abnormal. And loss of consciousness, I didn't know what happened to me. Somebody picked me up. But when I came back, I had no clue. So this gentleman for 2 months did nothing, never went to anybody, and managed himself. The last person was going around 1 year just asking his family physician to help him with symptoms, who was treating him for as usual, the gas issues, which went on for almost a year. Now, it also helps you understand that it is very easy for you to miss things, at the same time pick up things if you're quite watchful. So as an oncologist, you will end up getting umpteen number of cases, different diagnoses, different ways of presenting. So it will be absolute delight for a person who loves medicine and diagnostics to go through each of these patients and try and understand what their problems are and make a diagnosis. The good thing about understanding a clinical feature is that you would be able to diagnose these people with the minimal amount of interventions, minimal amount of scans, minimal amount of tests, because you have already narrowed down on what you think this person has. If you look at these pictures, this girl who was there had this lump which was on the side of her neck, and this elderly gentleman on my right hand side was quite visibly thin and leaned out. He had lost a lot of weight. You look at his abdomen, seems to be protruding out. So obviously there was something in his tummy. Unfortunately, this guy who came from Middle East was absolutely normal to our examination, and we found nothing wrong with him. We sent this person for a biopsy. The second guy, we had no clue what to do. We did scans and we found that his scans were normal. In the third person, we found a lump in the abdomen and we did a biopsy from there too. Now you realize that biopsy sounds a simple thing, but each of these departments that are involved with the treatment of these patients were different. The girl went to head and neck cancer, where Dr. Subramanian Iyer and his team helped us get this biopsy. On the other hand, the right hand side, the elderly gentleman had to be sent to a gastroenterologist who decided that it was safer that he undergoes a laparoscopic surgery and gets this biopsy done. So we finally sent him across to the gastrosurgeon who did this biopsy for us. Simple examples of how we would be able to make a diagnosis. The pathologist saw the initial biopsy and looking at that owl's eye appearance, immediately called it Hodgkin's lymphoma. Very simple, very easy diagnosis. On the other hand, we had a little struggle, but towards the end, we realized that this person who was elderly was having a diagnosis of non-Hodgkin's lymphoma and follicular type, which is a low-grade type, which was grade 2 / grade 3. We had no clue what to do with this man who was in the center. You look at the scans here. The girl had all those fluorescent areas that you see on the picture. This is a PET scan, and you would realize that we have so many arsenals now in oncology. It is unlike those old days when we had barely anything to work up our patients with. This is a PET scan which helps you figure out what is wrong with these patients in terms of how far their cancers have gone. And you would see that this girl has got a lot of those fluorescent areas or blackish areas that you're seeing on the scan, which is spread across her neck, her armpit, axilla, and also in the mediastinum. On the other hand, you look at the right-hand corner about the PET scan of the old man, you see this large lump, the fluorescent lump that is present inside the abdomen. That is what was pushing his abdomen out. We got the middle guy and tried to figure out what is wrong with him. We examined all his old scans, which was done in Middle East, and we found that there was something which was sitting right in the center of his brain, the fluorescent area that you're seeing on the screen with a blue line around it. But when we repeated his scans here in the hospital, we found that nothing was there. So we had to go back and pinch him and try and figure out what went wrong. Is it a wrong scan or is it actually something else? And we realized that he had already been to his local doctors and complained of headache, and somebody had given him steroids. After the steroids, it was already 3 weeks when he reached us, and we realized that it is possible that that fluorescent area or that hyperdense area probably has disappeared because of this use of steroids. And that gave us a clue, maybe this could be lymphoma. Now, you have these diagnoses of the girl having Hodgkin's lymphoma, the gentleman in the center having an issue with headaches, but you have something which was seen earlier, disappeared in 3 weeks. We suspect lymphoma, but we don't know what it is. And the third person, who is an elderly gentleman, we have biopsied and we found that he's got a gross big tumor sitting inside his abdomen, and that is now diagnosed to be a non-Hodgkin's lymphoma follicular type. Once you make a diagnosis, the next biggest challenge is to go across and tell the family what's happening. And this is something that is quite disastrous. The first one, I remember I went to break bad news. I cried more than the patient did. And the patient was pacifying me as to, don't worry, things will get better. Sometimes it becomes very difficult because we are all scientific people and very, very objective in everything. When it comes to telling people about bad things, it does hurt. And as caregivers, it might be very difficult to keep doing that same thing. Two things happen. Either you are continuing to be emotional and you break down and you burn out, or you become totally alienated, you don't bother, you just come and drop a bomb on the patient's family and then take a walk. Both of those things are quite difficult. So as an oncologist, it's not just about making a clinical diagnosis, it's not just making a fantastic staging workup and telling patients what you have scientifically done, but also at the same time being empathetic and trying to understand the patient's situation and trying to help them out, letting them know that you are right there to help them. There are plenty of ways by which we do breaking bad news, and that's something that you will find very, very heartening, because you get so close to these patients that you're treating. Unlike all the other places where you do an excellent work, probably the patients will respect you and all that, but the closeness that oncology brings in with your patient's family is amazing, and it is something that I've experienced and learned over many, many years, and I've understood that it has given me a new perspective in life. Now, this particular patient had a lot of questions. The young girl was really worried about hair loss. She was worried about how her ovary functions, because she's reading, she's an engineering student. She would worry about how her ovarian functions would be. The young man, we finally diagnosed as primary CNS lymphoma, because 6 weeks later, when we repeated a scan, when he had a second episode of headache and loss of consciousness, we found that the tumor had come back. So a tumor which was there, which disappeared and came back, would suggest that this patient had lymphoma, which was better off with the steroids. So we had to tell him that this is primary CNS lymphoma, and we did a biopsy, proved that it was primary CNS lymphoma, and then we told him this is the problem and this is what we need to do. But he wanted one more child, so he was really worried about having no children after he has chemotherapy. He also was worried about being the only breadwinner, which would obviously be of trouble to him. The third guy was more worried about his cardiac issues. He had stroke, he had TIA, he had poor logistics. He had a wife who was not keeping very well, and she was at home with him. His children were not there. As oncologists, you don't just give chemotherapy, you also go ahead and look at the things that will help them to get better and tide through the situation. What we have here is what is called the Paxman scalp cooling. This girl got it, and she had a good share of her hair which could be prevented from being lost. She had this injection called leuprolide, which helped her maintain her ovarian function. This middle guy was able to go and do a semen preservation. We had our MSWs who got together and helped him crowdfund. We also had to include multiple departments, including the cardiology and the neurology, to come and help us with this gentleman who was elderly. And also, we had to have some tough talk with his children who had to be brought in to help them out during this time of crisis. So the girl had Hodgkin's lymphoma stage 2. She was treated with a treatment protocol called ABVD, which was for 6 months. The second guy had primary CNS lymphoma, and he was treated with what is called as De Angelis protocol. Non-Hodgkin's lymphoma follicular was the diagnosis of the third gentleman, and he was treated with a treatment called RCVP, and which continued for 2.5 years. Now look at the treatments. You have one treatment different from the other. Each of these lymphomas were treated differently. They had different time periods of treatment. So even when you have a single diagnosis, the same category of disease, you still treat them so differently. That in itself is quite exciting. Once you treat these patients, they have a whole lot of chaos, confusion. And this is a time when you need to be on your toes. This girl had febrile neutropenia. That means her neutrophil counts went down to 200, and she had high fever. She had a Klebsiella pneumonia. She had to be put into the hospital and managed, which is what the infectious disease people would do. And you have this in your hand. On the other hand, the second gentleman, after all the treatment, came with recurrent hyponatremia, and we realized that he had something called SIADH. And that had to be generally SIADH managed by nephrologists and endocrinologists. You as an oncologist would be managing that. The third guy had accelerated hypertension and cardiac arrhythmias, both of which were cardiology-related issues, and you had an opportunity to treat. So in oncology, it's not just about giving chemotherapy, if that is what the idea is in your mind. It's about managing this whole person, both his physical difficulties, the chemotherapy-related issues, the emotional confusions that these patients go through. So you would have multiple opportunities to take care of them. All these 3 patients went into complete remission. That means all the signs of cancer that they had disappeared. The most powerful warriors, which are patience and time, is what is required in oncology. This is a statement made by Leo Tolstoy. But telling your patients to go on and live in the moment is quite a difficult task. You have to keep on motivating them to make sure that they continue to remain in the moment and don't worry about things that are going to happen in future. What happened to these three people? They were on surveillance, all these three, and they came regularly as advised to see the doctor. 2 years later, this young girl relapsed. That means her disease came back. She had to be sent for high-dose chemotherapy and bone marrow transplantation, following which she again achieved a remission. She got married and now works abroad. The second guy, the primary CNS lymphoma, he finished his treatment, did very well for 7 years, had a child. 3 years after completing the treatment, he returned back to his work and got a promotion. The non-Hodgkin's lymphoma 70-year-old man lived 8 years without any difficulties. His wife passed away 5 years after. He was so happy that he could take care of her till the end. But 8th year, 9th year, he came back with high-grade fever, and we realized that he has got a high-grade recurrence. He held my hands and said, I would not want any treatment, and he decided to go on to palliative care. 3 months later, he died very peacefully at home. His family came back later and thanked, saying he was so happy that he did not take treatment. So sometimes withholding treatment is also something that you could probably decide. When I started getting into the thick of oncology, these were the only 4 different combination of drugs that was used in lymphoma. But if you look at it today, this is how the list looks, the number of drugs that you have to help out these patients with non-Hodgkin's lymphoma. This is only one aspect of it if you just look at the number of drugs, but there are so many developments that has happened over many years. And we realize that we have so much of arsenal in our hands to help these patients who are in distress. Cancer is not something that's going to be a killer disease anymore. It's now become a chronic disease. And a lot of you would probably be able to come and join this and help these patients who are in distress. All that is required are these 3 things. And this is the aim or the primary thing that my alma mater has taught me. It said you should have 3 things. 1, you should be professionally competent. Second, every decision that you make should be socially relevant. And if by any chance you become a medical oncologist, you need to be spiritually alive, because if you're not, you're going to burn yourself out. If you have a combination of these 3 characteristics in you, or are willing to achieve these, you will definitely make a great medical oncologist. I hope I do have a few takers in the years to come, and I would probably be proud of the fact that some of you would have been my listeners this evening. Thank you very much for this invitation. I really enjoyed being with you. Good evening.
Thank you, Dr. Wesley. This was a very, very interesting, gripping, beautiful talk. And it really introduces people to the widespread concept of oncology. It's not just about treating, operating, or giving medicines. It's a whole new way to view a patient. And I'm so grateful for this lovely talk. Back to you, Aarti.
Thank you, ma'am. We would like to thank everyone who joined for today's session, starting with our chairpersons, Dr. Radhamani K, Dr. Subramanya Iyer, Dr. Mala Mathur Sharma, our guest speakers, Dr. V.P. Gangadharan, Dr. T. Subramanyeshwar Rao, and our speakers, Dr. Pavitran K, Dr. K. Vijay Kumar, Dr. Pradeep Jacob, and Dr. Wesley N. Jose. Also, I would like to thank our organizing committee and the AV team and the support staff for making this day possible for us. This session has been sponsored by Samarth Life Sciences and Cipla. You can also log into our website www.spasht.co.in and get more updates about the upcoming events. Thank you.
Thanks, Sarunima, and you thanked everyone, but I think the backstage there are a lot of people, and I think we started the plenary session with one on rheumatology today, and subsequently we had the second session on oncology, and I think it was wonderful. Both the sessions went off very well. We had very eminent chairpersons, very eminent speakers, and I think the kind of discussion which evolved. In fact, I was so much thrilled by the lecture by Dr. Jacob that I told him that I would like to attend a class when you take a full class, because I think clarity is there, the vertical integration was fantastic. So anyway, without wasting any more time, it's already touching 8 o'clock. So before we wind off, I thought it is a good idea to, introduce you to our team here. Arunima Chellappan is on my left. You already heard her. Dr. George, can you, Dr. George Matthew John, he's the associate professor in surgery. He's been, always supporting the SPASH from the, last few years. Then Manohar, Shyam is there. Shyam? Sorry, Manohar, no, Vishwas Manohar. Sorry, I stand corrected. Vishwas Manohar, Amalendu, then Arati, Steve, Samyukta, Shritu, and Vana Yatish Reddy. And then we have some people behind who are Jani, you can join in. Mrs. Jani is from our, principal's office. She's handling the NMC. She's always been doing great work for the, SPASH, the veteran of the various SPASH. And there's one more gentleman behind. Audio video team, we have Rajiv. One corner where? Rajiv is there. Rajiv, Deepu, and there were others, I think, who have left now, actually. Yeah, there were 4 or 5 to start with. So I, on behalf of the medical director, our medical director, Dr. Prem Nair, who's in Delhi today, actually, I spoke to him in the morning. He's gone for some of our work in relation to our the campus, which is coming up in Faridabad, some work. So he was discussing, and I just mentioned him about what was happening today. So we are very grateful to each one of you for having, taken time out to attend this. And today, I think it's touched about 1200 was the number. I think somewhere around 1200 odd was the first one. And then it was, going up and down depending on the, a lot of, especially when that's what we thought. That's why one of the purpose why we thought we'll go for plenary, because our previous experience was that you try to fit in too many things online, it's sort of, it's very difficult to sustain. The sustainability is very difficult. So we broke it. We have some now 13th, then we have 20th. 20th will be endocrinology and hematology. Then 21st we have, there's a talk for the students for how to prepare for NEET next. Dr. Ashutosh Oja is coming from Bombay, Somaiya Medical College. He's a very distinguished person. Officer, he was retired from the army, and then he's worked in, apart from AFMC, he's worked in Tata Main Hospital, and then now in Somaiya. So he's got a lot of interest in the subject, and I think that deliberation will be very useful. Then 26th to 28th, we have the main body of the program, where there will be multiple competitions, workshops. Then we'll have 2, panel discussions. One is on leadership challenge, and the second is on career options after MBBS. And this time in the leadership challenge, one of the, Veer Chakra awardee of the Kargil or Brigadier Bhaskar is coming. Same unit, 13 Jacrif, from which Captain Vikram Batra was there. So I think definitely Captain Batra, and I think it will be quite an opportunity. SP Wayanad is one of our alumnus is coming, and so and we are hoping.
You're going to motivate these guys to join army. I'm very happy about that.
Yeah, in fact,
they should. I'm very happy.
Yeah, one of our squadron leader, Srikanth, he joined. He was he did MD here, and we motivated him, and he not only joined, he also got a chief commendation in the first year, chief of air staff. So
these guys should be motivated. You should have more of these things, because they are a good lot, and it will give Amma great happiness to know that her students have joined army. She loves people from army. And it's an excellent career to join army. It's an excellent career. For a doctor, I mean, I'm from army, Vishal is there. We know we had a very beautiful time in army. Very satisfying, ethical practice, very fulfilling way of life. Your medical practice, your other profession, it's a very fulfilling way to live. And people with a lot of passion and all, they should be in army. They waste their time outside, because in civil life is totally different. It's very different work ethics. The only way where you practice ethical medicine, where you can follow your passion, is in army, or anywhere in defense. I mean, army, navy, or air force. So I think we should organize more to motivate these guys to join a career in service.
I'm always grateful to Mala, because she was, it was in 2008 when we were doing it. I think somewhere in August to September, October, 2008 we were doing the
Yeah, we did a
8
course.
or 9, sorry, 8 or 9, 9 it was, I think.
It was
9.
8. It was 2000. I think 2008.
9.
And it was 2009.
9 we were doing the senior command course. So in that course, she had come and like we are the same batch. So she gave me books about Amma, and that is the first time I read about Amma, Updesh Amritam, and various books. So that is the time, so that was actually the first time I came to the ashram was in 2010, and she was here only. So it's like, probably it was only Mala who probably motivated me, and today if I'm standing here is only she is the one who brought me here actually. And anyway, it is Amma's grace probably which brings us.
I think,
So,
Vishal, we should work more to motivating these guys to join defense.
I agree, and in fact, many of them have the right kind of, when I look at them, they are very highly motivated, and they have the right kind of personality and
for defense,
and also very compassionate in their approach. That's something which stands out when you work with them. You know that because you've been teaching them, and you've been here longer than me. So what I've seen that their thought process is very good actually. In fact, these are the kind of people now who can actually do well. They will do well everywhere, not only armed forces, wherever they go, be it central government, state government, or in private practice. And I think that's so.
I think they can contribute maximum, to the nation as well as to profession, to everything. They'll be a real asset in army, and they'll be having a very happy and fulfilled life.
Correct.
In a setup like civil, I know people struggling day in and day out, placements, pays, all those issues, that they are taken care of in army. You're not worried about your money, you're not worried about accommodation, you're not worried about what you want to eat, you'll get everything. You just do your work and enjoy life. Army is the best way to be, I am telling you.
Right. And I think,
If I have to live my life again, I would still be in army.
You can see, like, we were all, they were asking me, sir, one of the students was asking me the other day, say, when did you do MD? So I said, yeah, see, we have to serve as a medical officer. So you don't, you will do it a little later, then you do. So everything may take time, but it's all right. You will, you are in a job, you'll evolve gradually, and at some stage, so it doesn't really matter.
Actually, army has a way. You work as a medical officer for 4-5 years, and then you make a base as a medical officer, and then you specialize. And once you specialize, you work as a specialist for about 6-7 years, and then you super specialize. So you have you develop like a pyramid. You have a very strong base. So even if I'm an oncosurgeon, I can manage a gynec emergency, I can manage a pediatric emergency, I can manage a cardiac emergency, because I am first a doctor, then I am a surgeon, and then I am an oncosurgeon. But what is happening now is these guys finish their MBBS, they immediately specialize in, say, surgery, and then they go super specialty. Now, urologist, he cannot even diagnose an appendicitis. And a neurosurgeon doesn't know causes of fever. If somebody's fever, he wants to show to medicine. Or you treat your fever. They don't know how to treat fever because they have never worked as a general practitioner. So actually, you need to have a good base of working as a general practitioner, and then you should go for specialty. So the way system works in army, you become a complete doctor. You are not just standing on a pillar, sitting, specializing with no base. You just poo and then the whole thing falls down like a pack of cards. You have to have a base as a doctor, then as a specialist, and then as a super specialist. So you take time, but you're working throughout and you're earning experience and you have a job. So you can afford to, build up your base. So in army, any specialist can do any work. You can do as a medical officer. We all as specialists have done general duties. We know how to manage pediatric emergencies, gynec emergencies, everything we know. It's not that to become a specialist, I can't do any work and nothing else besides my work. So that is a kind of training which army ensures, that you have a very, very strong base as a doctor, then as a specialist, and then only a super specialist. So I feel that kind of attitude and behavior and training program and training and a mental attitude of a doctor is only can develop in army. In civil, it's a rat race. You finish this, you finish that. What job you will get next? Corporate setup. I do this fellowship. It's like a rat race, running after money, running after I don't know what. I don't like the way things are, and I would not be happy like that. And I would encourage all my students to work towards having a more complete life. You have to live a life as well, yeah. You just can't chase these goals. So if you that you only insured in army, in civil practice you cannot do. You just cannot have a life. You're running after goals, you're running after money, you're running after degrees, specialization, then corporate setup, you are at the mercy of the corporates. It's that's not a way to live. The only way to live a good life and be a good doctor is to be in army. That's my firm belief.
That's a good motivation coming from
And you have great bonds. You have great bonds in army. You bonding for life. You look at me, you look at Vishal. We was 35, 40 years back we were there. Today again we are together. And still civil you get scattered. You have no base. You have no bonding with anybody. So I feel that army is a good career.
So yeah, and actually, yeah, it's a good career, and you have a lot of options open for you. Do consider it as a career, and I can assure you that it's something. Like I really feel happy when I met the SP Wayanad. I met him about 3 years back of the Sukumar, Arvind Sukumar. He is coming, Dr. Sukumar. So he was telling me that he was determined to join the civil services and he wanted to join IPS. So, he went on. First, he cleared in the second or third attempt, then got IRS, then again gave the exam, got through the IPS. So, that was, I think, you got to chase your goals, whatever they are. Right? So, if somebody wants to, study in Mayo College, I think he has to decide at some stage and prepare accordingly. So wish you all the very best and thank you, Colonel Malamasar. It was wonderful
Bye
being
everybody.
here.
All the best.
And I thank all the speakers once again and the chairpersons, and I thank the entire team, and I thank all the viewers, all our students, the delegates for having come for this conference. And we are very happy that in spite of the fact that we are online, we are able to communicate well with each other, and I'm hearing that there are excellent entries in photography and the essay writing, and so it gives you get a feeling, like I think 8 or 9 countries have outside India also are participating. 9 or 8 or 9 have registered, Ukraine and Malaysia, Philippines,
Georgia.
so many, Georgia. So it's very encouraging for all of us. So again, we thank Mata Amritanandamayi Devi, Amma, our Sadhguru, for her grace. It's because of her grace that all this happens, and I'm sure with the grace we will continue to move on forwards. Thank you very much and pranams.
Bye, folks. Thank you so much.
Thank you.
Good. Sir,
Yeah, sure. Photo ले लो. अरे यार, Steve, एक photo ले लो.